you in surveillance and response working groups annual meetings for the year 2022. This year, we are fortunate enough to convene an SRWG meetings in person here for the first time in Bangkok since 2018. I am delighted to see many familiar faces as well as new colleagues among those present here today. APMEN and the three working groups, we have been the cornerstone for engaging dialogues and supporting ongoing informations exchange across country partners and partner institutions in the Asia Pacific regions. Furthermore, our close partnership with the Asia Pacific leader Malaria Alliance with host leaders and key stakeholders in the regions has enhanced our strong commitments to eliminating malaria in the Asia Pacific by 2030. This year, we meet ahead of the leaders conclave, which will be held in New Delhi in January next year, 2023. Colleagues, ladies and gentlemen, the theme of this year's annual meeting is strengthening national malaria program surveillance and response through defining data needs for malaria eliminations. As we move forward, our goal of eliminating malaria in the regions by 2030s, high quality surveillance data is increasing vital to ensuring the functionality of our programs. For both designing interventions that target the last remaining fossils and ensuring that we accurately measure our progress towards eliminations. Over the past 2 years, during which I have been chair of these working groups, together with Professor Richard Muth from the Maidon Oxford Tropical Medicine Research Units, our goal has been to reorient the working group's priorities based on the country program needs with regard to malaria surveillance activities. Our new meeting will provide us with on the opportunities to collect your feedback and guidance to strengthen the SRWGs as a platform for impact in these regions. To start off, today's proceedings will begin by highlighting the importance of surveillance, data quality assessments, and reporting metrics from the perspective of WHO's and global funds. Together, we will also identify data quality challenges in various dimensions and potential solutions, both through our breakout groups discussions and landscaping of data quality projects and available resources and support from our implementing partners across the regions, as well as between regions. Cross-regional collaborations will be further emphasized moving forward to minimize overlap in our respective works and to amplifying efficiencies of knowledge sharings across our unique platforms. Tomorrow, we will hear from our colleagues in various national malaria control programs, the session on high quality data for targeted surveillance interventions will bring together the implementations perspective from across these regions to share the surveillance best practices and discuss remaining challenges within the programs. We hope that by sharing our experiences with one another, we can identify instances where certain strategies have worked and where improvement may be needed. Lastly, throughout both days, we will be fine-tuning the work plan of the SRWGs for the years 2023 and 2024. As such, I strongly encourage your full participation in the breakout group sessions in these afternoons. to ensure that our upcoming activities meet your needs, including formulating and updated sets of operational research priorities. With these last points, I would like to take these opportunities to thank you, all of you, our distinguished speakers, facilitators, the coordination teams who are always stay behind but do an excellent jobs. And of course, dear participants, friends, and colleagues from across the regions who have either flown from far ways to be here in person, and also those who are now tuning in online. Thank you very much for your participations and contributions. I wish you a successful deliberation. Thank you very much.
Thank you, Dr. Ranasai. So next, we will invite Ms. Amita.
Hello, can you hear me?
Can you wait for a second? So as you all know, Ms. Amita Shebi, she is the Executive Vice President, Advocacy and Program from APMEN. It's a bit slow. Okay, so that everybody can see your face, your beautiful face. Okay, all yours.
Thank you. You're very kind. Good morning, everybody. Dear Dr. Ratna Sai, Dr. Surawadi, Dr. Mushtaq Ahmed, colleagues from national malaria programs across the region, and friends. APMEN meetings are always very special. And this one in particular, as it's happening in person after almost 3 years, is a very special moment in time. I really wish I could be there in that room with you, but unfortunately could not travel. But I have my colleagues from APMEN who are there, and really looking forward to these 2 days of discussions. COVID affected our lives in many ways over the last 2 years. But one of the unintended fallouts, I think, of the pandemic has been the fact that surveillance and response are now household terms. These are terms that are recognized, identified by the man on the street. And I think in many ways, this really represents an opportunity for all of us at the Surveillance and Response Working Group to utilize this moment in time to highlight and advocate the need for stronger investments in surveillance and response, the need for more integrated mechanisms that will allow for real-time monitoring, data reporting, and ensuring that there are more integrated systems that work across disease areas in the ministries of health. So I think this is a very unique opportunity that we need to capitalize on. And the SRWG has been doing a fantastic job over the last 2 years of highlighting these challenges and advocating for continued investments in surveillance and response mechanisms. Many of our countries that are part of the APMEN network are also part of the E2025 cohort. And for them, elimination is in sight with a 2025 deadline. And for these countries in particular, the importance of surveillance and response in near elimination settings is very critical, because it is indeed the last mile that is often the hardest. And it's absolutely important to be able to track and respond to every single last case. So for these countries, I do want to highlight the fact that the SRWG stands ready to provide technical assistance as needed to fill any outstanding gaps and challenges that you may have on your journey towards elimination. Having said that, I also do want to recognize all the other countries that are part of APMEN that may not be part of E2025, but that are continuing to make progress towards their elimination goals. This year was particularly important. We saw several countries in the region. They went through their midterm program reviews, India, Indonesia, to just name a few. A few countries are also in the process of updating their national strategic plans. And I think this represents a good time for us to refocus attention on surveillance and response as critical tools that are important to get to elimination. So with that, I'm going to wish you good luck for the next 2 days of deliberations. As Dr. Ratanasai highlighted, the breakout sessions are absolutely critical because those are places where we want to hear from national malaria programs, want to identify the continued challenges that you face, and really help us identify priorities that will guide in the setting of work plans for the next 2 years. This meeting is really for all of you at the national malaria programs, and we welcome your inputs and wish you all success on the 2 days of meetings. Thank you.
Thank you, Amita. Thanks so much. Last but not least, please, Professor Richard, our co-chair, to provide the welcome remarks.
Thank you, Paul. So we're testing the formats here. A warm welcome, everybody. I hope you don't mind. I'm going to sit here to give my opening remarks. So welcome to our home city of Bangkok on behalf of Moru and also on behalf of APMEN. It's great to see everybody here, and we're very excited that we're finally having an in-person meeting. And we have this hybrid format, so we can see there's 20 people currently online. We have about 50 people registered that will join for different sessions. Some of the presenters will be online and some in person. We'll have a combined format, but hopefully all the technology will work fine and we'll be okay. So the guests from APMEN country partners are in the inner U in this room, and then the outer U is the partner organizations, partner institutions. We have some special guests, including on my left, Dr. Champa Alutwira, Director of Anti-Malaria Campaign from Sri Lanka. And then online, we also have Professor Zhao Nongzhu, Director, National Institute of Parasitic Diseases from China, CDC, and Dr. Mohammed Mukhtar, Director of Malaria Control, Ministry of Health Services, Regulations and Coordination from Pakistan. So they'll be joining at different points. In addition, just like to introduce, we have a Moru team, so our support team. You'll have met some of them at the desk, and there are others, including Paul, and we have Marina, who's the organizer of the meeting, who's sitting over there. Can you put your hand up, Marina? So if you have questions, you can ask people. They're either the ones that you saw at the desk or Marina. And then there's also, I can see Chaurat sitting in the corner. Chaurat, can you put your hand up? Thank you. As we have 10 minutes before we do a group photo, we're going to do a quick round of introductions for people in the room. We'll see how far we get within the time. So we have microphones at the front desk, so we can use your microphones. You can press the button. You can see a little symbol of a person with a voice. So if you press that button, you can then speak. And we'll go around the inner circle, and then we have a walking mic. So there's a portable mic that people can pass around as well. So we'll start over in the corner, my right here.
So good morning and very welcome to all. I'm Dr. M.D. Mushfiqur Rahman. I'm epidemiologist, National Malaria Elimination Program, Director General of Health Services, Bangladesh.
Assalamu alaikum and good morning, everybody. This is Dr. Mohammad Nazrul Islam, Monitoring and Evaluation Expert, National Malaria Elimination and AIDS Transmitted Disease Control Program, Director General of Health Services, Dhaka, Bangladesh.
Good morning, everyone. I'm Dr. Mitha from National Malaria Program of Cambodia. Deputy Director of the CNM Cambodia.
Good morning, everyone. My name is Poli. I'm the medical doctor. I work for National Malaria Control Program of Cambodia. My title responsible is for the Deputy Chief of Technical Bureau and Village Malaria Worker Program. Thank you.
Good morning, everybody. My name is Edi Sunandar. I'm Epidemiologist. I am from West Papua Province Health Office, Indonesia.
Good morning, everybody. My name is Hermawan from National Malaria Program Indonesia. I'm an entomologist. Thank you.
Good morning, everyone. I'm Dr. Odai Sitangtip, Technical Officer for Epidemiologist from National Malaria Control Program of Laos.
Good morning, everyone. My name is Kamsuan Kamsi from CMP Laos. Thank you.
Good morning. I am Gail Bukhapon Jindawongsa, Deputy Director of National Malaria Control Program from Lao PDR. Thank you.
Good morning. My name is Nonipa from Department of Communicable Disease Control, Laos.
Dr. Mir Yusuf Khan, Director Malaria Control Program, Balochistan, Pakistan.
I'm Dr. Mushtaq Ahmad Shah, Deputy Director General, Vector-Borne Disease, Sindh, Pakistan. Thanks very much and good morning to everyone. This is a very great opportunity and great initiative for our developing countries to eliminate the malaria in the right time. Thank you all. Thank you.
Okay, once again, I'm Dr. Ratanath Sai Pitsuban, the Director General of the Department of Communicable Disease Control under the Ministry of Health Laos, and I'm also the co-chair of the APMEN's SRWGs. Thank you very much.
And I'll do the same. So I'm Professor Richard Maud. I'm professor at the University of Oxford. We're based at Mahidol Oxford Tropical Medicine Research Unit in Bangkok, where I'm head of the epidemiology department, and I'm co-chair of the APMEN SRWG. Thank you.
Warm greetings from Sri Lanka. I am the Director, National Anti-Malaria Control Program, Sri Lanka. I'm Dr. Champa Aluthweera. Thank you.
Hello, good morning. I'm Dr. Samantha from Anti-Malaria Campaign Sri Lanka. I'm in the Maternal Monitoring and Evaluation Unit, Sri Lanka.
Good morning, everyone. I'm Leonard Boas from Solomon Islands. I'm the Deputy Director of the program. Thank you.
Hello, everyone. My name is John Laburi from Solomon Islands, work as the M&E officer. Thank you.
Yeah. Good morning, everyone. My name is Thắng. I will work in NIMPE, National Malaria Program in Vietnam. I specialize in data management and surveillance. Thank you, Moru and APMEN, to organize this meeting for the NNCP here to learn the lesson and sharing the experience. Thank you very much again.
Good morning. I'm Dr. Thắng. I'm the Secretary of Vietnam Malaria Program. Thank you.
Hello, everyone. Good morning. My name is Jirasak Khatpong. I am medical entomologist from Division of Vector-Borne Disease, Thailand. Thank you.
Good morning สวัสดีค่ะสุรวดีกิจการ from Division of Vector-Borne Disease Ministry of Health Thailand. Thank you.
Good morning. My name is Kinle Wangdi. I'm a researcher from Australian National University, and my area of expertise is spatial mapping. Thank you.
Good morning, everyone. My name is Leo Brock. I'm a medical entomologist with Malaria Consortium based here in Bangkok, also co-chair of the APMEN Vector Control Working Group. Wonderful to see everybody assembled here. Thank you.
Good morning, everyone. My name is Diana. I'm from Papua New Guinea Institute of Medical Research. I'm an epidemiologist and I work mostly on surveillance of malaria in PNG.
Good morning, everyone. My name is Dr. Win Han U. I am from Barnet Institute. I'm the regional program manager for the health security and malaria for the Southeast Asia. Nice to see you all.
Good morning, everyone. My name is Leanne Gallerano. I'm from Population Services International, Regional Program Manager for Malaria Surveillance and Emergency Operations Centers.
Good morning, this is Akramul Islam. I work with BRAC in Bangladesh as a partner of National Malaria Elimination Program, and I'm a senior director in the BRAC.
Good morning. My name is Jui Shah. I'm with RTI International based here in Bangkok and supporting the National Malaria Program of Thailand with surveillance leadership.
Morning, everyone. My name is Elijah Phillip. I'm a regional epidemiologist and technical advisor for the Clinton Health Access Initiative based in Cambodia.
Good morning, everyone. My name is Hannah Edwards. I'm a senior technical advisor at Malaria Consortium. I'm based in the London office, but give support to the Asia region on surveillance and data-informed response. Thank you.
Hello, good morning, everyone. My name is Hulan. I'm technical officer at Malaria Consortium based in Bangkok. I'm also supporting APMEN of the WG as technical officer, mainly for capacity building activities. Thank you.
Good morning, I'm Logan Wu. I'm a PhD student at the University of Melbourne and Shanghai Jiaotong University.
Hi, I'm Yalda Jafari. I'm a DPhil student at University of Oxford based here at Mahidol, Oxford Research Tropical Units.
Hi, my name is Jade Ray, and I'm an epidemiologist at the Shoklo Malaria Research Unit in Mesot.
Hi, I'm Greta. I'm a doctor in public health, and I'm currently doing my PhD at University of Hong Kong with Moru.
Good morning. My name is Panarasi Konpusa, epidemiologist at Moru, Mahidol, Oxford Research Unit. Thank you.
Good morning, everyone. My name is Vilayvon Malapon. I'm an endgame project in Laos, PDR, working closely with Sempe in Laos.
Hi, everyone. My name is Kunchada Pongsaipet. I'm a special data engineer at Moru Epidemiology Department. Thank you.
Hi, good morning, everyone. I'm Caroline Lynch. I'm the regional advisor for Medicines for Malaria Venture here in Thailand, and I'm the co-chair of the APMEN Vivax Working Group.
All right, thank you. We will not forget people online. Okay, so please, online participants, could you please unmute, turn on your mic, turn on your camera if possible. We will start alphabetic order starting from Alonso. No, Alonsi, sorry. Alonsi, please.
Hi, everyone. My name is Elsa Alonzi. I am the communications officer here at APMEN in Singapore. Nice to meet all of you.
ACT Malaria, Cecilia Hugo.
Hello, good morning, everyone. I'm Cecilia Hugo, the Executive Coordinator of the Asian Collaborative Training Network for Malaria.
Ms. Deva, please.
Hello, good morning, everyone. I'm an academician and researcher for Department of Tropical Disease and Prevention and Control for Malaria for Mother and Child, Indonesia. Thank you.
Thank you. James Kelly, please.
Hi, good morning, everyone. James Kelly from Wipro, team leader for malaria and vector-borne diseases. I apologize, I'm not there in person.
Next, Jianhai Yin.
Hello, everyone.
My name is Jian Haiying from National Institute of Parasitic Diseases, China CDC at Shanghai. Nice to meet you all. Thank you.
Next, Kiel Mon Win.
Good morning, everyone. I'm John Mowen from a National Malaria Control Program, Myanmar. Nice to meet you all.
Thank you. Leanne. Hello.
Hi, everyone. I'm Mahesh. I'm Regional Advisor for PSI, joining in from Nepal.
Thank you. Next, Muhammad Omar Ishaq. Are you there? Muhammad? Omar? Okay, let's skip to Molly. Molly Robertson, hi.
Hi, good morning, everyone. Molly Robertson with the Global Fund joining from Switzerland. Thanks.
Thank you. Naomi, next, please.
Hello, good morning, everyone. My name is Naomi Waithera, Head of Data Management at Moru, joining in from Bangkok.
Thank you. Next, Pengbi. Hi, Pengbi. Pengbi, are you there? This is Paul.
Hello, can you hear me?
Hi.
Hello, do you hear me?
Yes, I can hear you.
Yes, sorry. Hello, everyone. My name is Baby. I'm a head of my information system unit. Hello.
Hello, yes, thank you. Oh, let's pop on ping up. Where is it? Next, Monash, please. Monash. Monash.
Hi.
Oh, where are you? Can you hear me? Monash?
Hi, can you hear me?
Yes, I can hear you now.
Yeah. I just want to say hi to everyone. I'm Manas Shrestha from the APMEN Vivax Working Group. Sorry, I can't put my video on at the moment. So just wanted to say hi to all you guys and best of luck.
Let me see. Okay, Popo Ang, please.
Hello, good morning, everyone. I'm Popo from Malaria Consortium.
Thank you. Professor Prakash. Hello.
Hello, very good morning. Do you hear me?
Yes, I can hear you, sir.
Very nice to meet even virtually. Apologies, I'm not able to participate physically. I represent APMEN Partner Institute, Tribhuvan University, Central Department of Microbiology. I'm a professor of microbiology and working in malaria in collaboration with Menzies and many others. Thank you. Nice to meet you.
Thank you. Next, Satapana. Satapana.
Good morning. I am Sarapana Navalan, working for RTI to support Division of Vector-borne Disease, Thailand Ministry of Public Health for malaria elimination goal. Thank you.
Thank you. Next, Tammo. Tammo.
Good morning. I'm Dr. Tam. I'm actually a Public Health Division for Malaysia under the National Malaria Program. Thank you.
Thank you. Do I miss anyone here online? API Nimpe? API Nimpe? The participant from APMEN.
Sorry, it's we.
All right. Okay, thank you. You are here. Okay. The participant from PNG. Is there anyone online?
Yeah, I am.
Yes, please, sir.
Sorry, I'm Leo Makita. I'm from PNG. I'm sorry I wasn't able to make it, but I'll participate here in any case.
Thank you. So we also have the participants here as well on the I row. Okay, let's start with Steve. Hey.
Yes, good morning, everybody. I'm Dr. Steve Ebner. I'm the lead of the Health Geolab group, which was recently established at Moru under the Department of Epidemiology to support the programs in countries with the management and use of geospatial data and technologies. Thank you.
So good morning, everybody. My name is Sajid Ibn Zaman, working as a data manager and GIS specialist at Moru Epidemiology based in Bangladesh. Thank you.
Hello, hi, I'm Pooja from APMEN, Asia Pacific Leaders Malaria Alliance, working from the Secretariat in Singapore. Thank you.
All right. I think it's all done. Oh, Dr. Leo Makita, your name is pop up here.
Yeah, I did introduce myself just
Okay.
a while ago.
All right. Okay. Thank you. So now it's a group photo before we fall asleep. Everybody, please stand up, please, and then welcome on the stage. We're gonna take a group photo before we have a discussion and presentation, and before we have a coffee break, please. And we also take a photo with the online participants as well. If online participants, please could you turn on your camera so that we can take your photo together with the person here in the meeting room. Okay, we're gonna take a photo with the online participants first. And then we're gonna have another shot for only person here in the room. Oh, the IT. Please turn on. All right. Okay, we can see we can see online participants on the back. Okay, that's great. Let's take a look. Okay, let me check.
I don't mean to have any offense. Try this out.
So online participants, please be patient. We're setting up. So photographer, are you ready? Can you capture all? Okay. All right, online participants, please be ready. 1, 2, 3. 1, 2, 3. One more. 1, 2, 3. Okay, thank you. Oh, please stay, please stay, please stay. Please stay, please, because we want to only with the logo.
So online participants, just give us about 5 minutes to take in-person pictures, and we will start the first session in shortly. Thank you very much for your patience.
Before we start the presentation, if anyone would like to go to the bathroom, please do.
Dr. Laura, are you in call right now? No.
No, okay.
All right, so we will be playing the presentation from Dr. Laura, pre-recorded. I believe it will take about 20 minutes. So phone, whenever you're ready.
Apologies, tech problem again. So let's wait for a few seconds. Okay, here it comes.
And I'm going to be talking. Good morning, Laura Anderson. An epidemiologist working for
This is not going
this year, WHO. Good morning. My name's Laura Anderson. I'm an epidemiologist working for the Global Malaria Programme at WHO. And I'm going to be talking to you today about measuring surveillance data quality, focusing mainly on the surveillance assessment toolkit that's recently been launched by WHO. So this year, WHO launched a malaria surveillance assessment toolkit to help countries to carry out systematic surveillance assessments. And this comes along with an implementation reference guide, which is a step-by-step guide on how to carry out the assessment and how to use the tools in the toolkit. The tools can be downloaded from this website in English and in French. And there's a whole set of tools to help countries carry out a data quality analysis, which is what we're focusing on today. The toolkit is based on an assessment framework with 4 key objectives. The first objective is to measure the performance of the surveillance system, which is defined by surveillance system coverage, data quality, so completeness, timeliness, concordance, and consistency, and data use. And this is what I'm going to focus on today. But just to say that the other 3 objectives are important in our understanding of why we see the results from evaluating the performance. For example, the other objectives look at the tools that are used for recording and reporting, which sectors are reporting, which information systems are used, and whether staff are adequately trained, for example. So I'm going to talk now about the indicators to assess data quality as part of the surveillance assessment under Objective 1, performance. The first is on surveillance system coverage, and you can see here that there are actually 9 indicators under the sub-objective. The reason we look at surveillance system coverage is to try and understand how well the system is accurately capturing cases and deaths. You can see here this example from Pakistan. The red line shows the reported confirmed cases, and the black line is the estimated cases from WHO. We often get questions about, why is there such a big gap? And that's because we're making adjustments for all of the layers in this onion you see here, where cases might be missing. So if we start with the top layer, these are people who have no access to healthcare. So they have malaria, but they're not accessing healthcare, they're not being diagnosed and treated, and they're not being reported. And sometimes we can estimate this from survey data. The second layer are those that have access to care but do not attend. This is the passive care seeking rate. It usually comes from surveys. The third layer is cases that present to healthcare, but they're not diagnosed and treated. So here we can look at the proportion of suspects that are tested. We can get this from routine data or survey. The fourth layer are those that are diagnosed and treated by private providers, but are not reported. Here we're looking at the service delivery participation rate in the country. Again, we can get this from routine data or survey data. The fifth layer is those that are diagnosed and treated by the NMP, but they're not reported. Here we're looking at service delivery reporting rate and reporting completeness, and this usually comes from routine data. And finally, the last little layer in the middle are the reported malaria cases, those who seek care, diagnosed, treated, and reported. The size of these layers really depends on the country. And so what we're trying to do here is try and get as much information as we can about each layer, so we can identify where the main gaps are and where the countries have to try and improve. When we look at the passive care seeking rate, this is the proportion of the population that are symptomatic with fever who seek care. It's normally coming from surveys, and there are a few things that we need to consider. So rather than just reporting the care seeking rate overall, we need to consider when the survey was done. We need to look at the differences between the sectors. So you can see here in Pakistan, the majority are seeking care in the private sector. And then if you imagine that a lot of the private sector is not integrated into the NMP, then you're missing quite a lot of cases. There might be differences by geography around the country. And we can try to think about what would affect the care seeking. So, for example, it may be affected by services that are free in certain sectors. There may be differences in care seeking behavior in countries. Some might prefer to go to traditional healers or the pharmacy first, which are not included in reporting. And there may be certain groups that are excluded as well. For example, people in rural areas with no access at certain times of year. For example, if there's flooding, parts of the population like illegal immigrants that have no health insurance, that may not access care. And so we have to think about all of these things in order to think about the strategies that need to be implemented to ensure universal health coverage. So when we assess this as part of the assessment, as I say, it shouldn't just be a number that we put in there. We should try and tease apart all of these issues so that we have a very good understanding of where the gaps are. To look at the proportion of suspects tested over time, if you collect the number of suspects directly in routine data, then this is a simple calculation of the number of suspected cases that receive a parasitological test divided by the suspected cases. A couple of things to keep in mind is that whether the definition of suspected cases is clear in the country and whether this definition is used throughout the country in the same way. And then if this data is not available, it can be calculated. You can calculate the suspected cases from the presumed, which are the clinically diagnosed and treated, plus the microscopy tested, plus the RDT tested. So I just want to point out some things to consider when we are looking at testing data. In country 1, it looks like RDT has not been implemented. But actually on further investigation, we find that the RDT has not been collected on the form. And in some cases, there may be stock out of tests. So although when we look at these indicators, we have a starting point of this data and we might assume something, we need to investigate a bit further to find out the reasons for that. For country 2, we can see here that RDT testing is going up over time and microscopy testing is going down. In some countries, RDTs and microscopy are carried out in different clinics, but in some, we have follow-up microscopy tests of all RDT tests, in which case there will be double counting. So we need to make sure that we're always correcting for double counting in tested and in confirmed cases. And we also need to consider whether there's double counting across different sources of data, such as the lab or the OPD register. Here we're looking at the proportion of service delivery points that are included in the surveillance system, public and private. For this, we need a master facility list as the denominator. If this doesn't exist, then we recommend that a country maps out this list. Then we're looking at the proportion of service delivery points included in the system that report routinely. And this includes facilities reporting 0 cases. After we've looked at all of these indicators I've just covered, we can put together this sort of chart. This is an example from Ghana. And in the blue, this is the proportion of cases that are captured at each level. And you can see as we go down, remember the layers of the onion, there's a proportion of cases that are dropping off. And in the end, we found that approximately 65% of cases were not captured by the surveillance system. And these are the adjustments that we're making between the reported cases and the estimated cases. In elimination settings, we're expecting 100% of cases to seek care within 48 hours of symptom onset and 100% of cases with symptoms to be diagnosed within 24 hours. The reason that these indicators are so important is because we want to make sure we reduce the chance of transmission by rapidly diagnosing and treating cases and making sure that case investigation is done. And it also ensures that all cases are confirmed through diagnosis of rapid testing. Things we need to consider is that some countries are not collecting data on symptom onset. Often the community may not be aware of what the symptoms are. and they may not have access to care also. So all of these things affect these indicators. So now we're looking at coverage of deaths. Most countries are focusing on the surveillance system coverage of cases, but it's equally as important to ensure that all deaths are being captured. In most malaria surveillance systems, they are not capturing all of the deaths because they're only capturing those individuals who die in hospital. So it's important to look at other data sources. One data source could be a CRVS system. This is a civil registration and vital statistics system. It should be well functioning, which means it should cover 90% of the country and include hospital and community deaths. It should use ICD-10 or 11 coding, and less than 10% of these codes should be ill-defined. And ideally, this data should be routinely analysed, and there should be reports or data accessible through systems or websites, or at least you should be able to request this data. And here's an example we have. The dark purple line at the bottom are the malaria inpatient deaths captured through the malaria surveillance system. If we only have this data, it looks like these deaths are increasing over time. But if we look at the malaria hospital deaths from the CVRS, which is a light blue line, you'll see that this line is flat. And over time, the malaria inpatient deaths come closer to that. So this is indicating that previously there was some gaps in the malaria surveillance system. However, if we then look at the green line from the CRVS, which comes from hospital and community, we can see that compared to the light blue line, there are a high proportion of community deaths. And then we can see that these are not being captured in the malaria surveillance system at all. So this would be a gap that the country could work towards to improve. So now for the data quality indicators, we first have to think about what data problems we can have. There can be missing values, so test results missing, for example, inaccurate values, so age listed as 80, but actually the date of birth was 1980, invalid or unclear values, so perhaps the case is microscopy negative, but then there's a species listed as P. falciparum, inconsistent or implausible values, so you have less RDT tests than RDT positive, or maybe the age is 150 years, or the case is a man but being recorded as pregnant. You can also have duplicate records in the lab or in the OPD, and you can also have missing records from registers. There are several ways we can address these kind of data problems. The first is through manual inspection of the registers. So periodically, and this is what we do through supervision from the district, for example, to the clinic level, they can inspect these registers for the duplicate cases, look for the completeness of records, the inconsistency of data, and the accuracy of data. If there's a case-based electronic system, then cannot be exhaustive. They could also have bugs. And we also have to be very careful about mandatory fields which prevent data from being entered or reports submitted. So what we don't want to do is put so many checks in place that it prevents somebody from entering a record and then they just miss it. And of course, the data problems may not always arise at the data entry level, but they may arise afterwards at the reporting level. And this is where we're looking at completeness of reporting, timeliness of reporting, completeness of core variables, consistency between core variables, internal consistency of core indicators, concordance between reporting systems, and case classification. And all of these checks can be done after data entry if we set up routine validations in a system or through data extraction and then running it through certain validation criteria. So a very important indicator is completeness of reporting. This is the percentage of expected reports received in a specific time period. Now, if you look at the graph on the right, this is the cases, total confirmed malaria cases from Pakistan. And you can see that from 2016 onwards, there was a big increase in the number of cases, almost double. If you look at the graph on the left, from the surveillance assessment, we found that if you look at the black line first, we found that in 2017, there was a big drop in reporting completeness, but then it seemed to recover again in 2018. Actually, the reason for that drop is if you look at the red line, this is the number of health facilities expected to report, and the blue line is number of health facilities reporting. There was a rapid expansion of health facilities diagnosing and treating malaria during this time. And so in such circumstances, it's perfectly normal to have a drop in reporting completeness whilst these health facilities come on board with the reporting process, using the same tools, being trained in the tools, and having the same supervision. So when we look at reporting completeness, we shouldn't just look at the reporting completeness itself, but we need to look at the number of health facilities that are functioning over time and expected to report. And then we need to look at all of this data alongside the epidemiological data to see if it can explain the trends. It's also important to look at reporting completeness by district and not just at the national level. This will help us to understand which districts in particular have issues. If we focus on 2017 here, the year of the expansion of facilities, you can see that in the public sector, all of the red are new facilities that came on board in Pakistan. And if we then compare those to 2018, you can see that the reporting completeness improved between those 2 years. Some other things we need to consider though. So if reporting completeness is consistent over time, then trends can be trusted. So obviously you want reporting completeness to be good, but even if it's bad, if it's consistently bad, then the trend can be trusted and the appropriate adjustment for the gap can be made. If you have reporting completeness that's going up and down, it becomes very difficult to interpret the trends that you're looking at. The second thing to mention is that reporting completeness gives equal weight to all facilities, and it may not reflect case reporting. So what I mean by that is, if you have 5 facilities that don't send any reports in, but the reason for that is because they have 0 cases or very few cases, that's very different to missing 1 facility that has the majority of the cases. But when we look at reporting completeness and we adjust for the cases missing, we are assuming that each facility has an equal number of cases, which is incorrect. So it's very important for countries to carry out good supervision on reporting completeness and understand which facilities are missing in each district and what proportion of all the cases are therefore missing. Timeliness of reporting is the percentage of expected reports received by a reporting due date. in a specified time period. The reason that this is important is because late reporting leads to problems in detecting and responding to changes and trends in a timely way. If you're not receiving the data until 6 months later, it's too late to do anything about, for example, an outbreak. It can also lead to batch reporting, where several reports may be sent in at the same time, which makes it look like there's a sudden increase in cases or deaths, which is not the case, and this could result in wasted public health action. But it can be difficult to look at this indicator because what you need is a system where a specified date has already been included, and reports that are not received by this date are flagged. We also have to make sure that reports are not blocked from being submitted if they're late. Often countries implement a system that if the report has not been submitted by a certain time, then it becomes closed. And then we end up with missing reports. And we need to make sure that case-based data is captured in the system in a way that it appears in the correct period based on the date of diagnosis or notification rather than date of entry into the system, if these dates are different. If you display cases based on the date of entry into the system, you risk this batch reporting issue again, where if an admin data entry person has been very busy, they may enter all the cases for the last 2 weeks at the same time and they'll appear on the same date. So something to watch out for. In an elimination setting, we're interested in these timeliness indicators. So time from symptom onset to health seeking, time from health seeking to diagnosis, and then the last 3 are all from the time from diagnosis to notification, case investigation, and focus investigation. The targets for the countries are shown in the grey, and if you look at the result, you can see that in the majority of cases, they have met the targets or done even better than the targets, apart from the timeliness of health seeking. So from looking at these indicators, the country can tell that they need to improve slightly, so we get 100% in this notification, case investigation, and focus investigation. But the biggest gap is people seeking care from their symptom onset. For reporting completeness of core variables, we have a minimum suggested number of core variables that should be collected and should be complete. These vary slightly between countries using aggregate data and case-based data. For case-based data, all of the date variables are obviously very important. However, the way that this works is for aggregate data, it's a % of reports received in a specified time period where all the core variables are complete. And for case-based data, it's a % of cases that have all of these core variables complete. We can present the completeness of variables by district and by variable. So then we start to understand where the problems are. Here you can see in Ghana, in Ashanti and Greater Accra, almost all the reports had some variables missing. Whereas if we look at by variable, we can see here that in all of the regions, there was a problem with reporting of presumed cases. And actually, it was found this is because the system does not allow the capturing of 0 cases, and they're not having any presumed from those areas. And it's important to put these data quality indicators also side by side by district or region, for example, because then we can understand whether there's common problems between different regions. We can also learn best practices from different regions if they're doing very well. And just to highlight here that in some areas, for example, here Kasai has very good reporting rates, slightly less better timeliness of reporting, but then a much bigger problem with variable completeness. So although the reports are coming in on time, they're not complete. So each individual district may have different issues, and these issues should be tackled differently in different areas. So another check we do is consistency between core variables. So these are a set of suggested consistency checks that are done on aggregate data, and they're quite sort of straightforward. You shouldn't be having more positive cases than tested, or more malaria inpatients than all inpatients, for example. In an elimination setting, most of these consistency checks are around the date variables. And again, we're looking at the number of reports that pass all of the consistency checks, or number of cases that pass all the consistency checks over the total number of reports or cases. The last indicator I want to talk about is the concordance of core variables between two reporting systems, or cases between two reporting systems. So this is the proportion of values that match between two reporting systems capturing the same data. So it's important to compare the number of malaria cases and deaths and the core variables between two systems in the country if there are two systems capturing the same data. This could be an MIS versus the HMIS or IDSR system or lab, or the CRVS, as I've already mentioned. And this is to ensure that the cases and deaths are being captured in the National Malaria Surveillance System and that this data are accurate. So in doing these comparisons, we need to make sure that we're comparing the numbers and the values for the same geographical area, the same time period from both the reporting systems, and very important to ensure that the case definitions are the same in both of the systems. If they're not the same, then we cannot do the comparison. Now, this comparison will allow you to validate your malaria surveillance system in the sense that we'll be able to know if it actually captures the cases and deaths in the country more accurately than any other system. And if that's not the case, it will help you to put things in place to improve that system. Or in an elimination setting, it will also help you to evaluate another system that's in place, for example, an HMIS that may be expanded throughout the country. And this may be the system that remains in place once malaria is gone. That means we need to make sure that that system is fit for purpose. This kind of comparison and evaluation will tell you whether that system is fit for purpose or not, in which case you can report back to other areas of the government that that system needs improvement, or you can use it to advocate for the fact that the malaria system, surveillance system already in place should be used instead. It's important to add that the surveillance assessment is predominantly carried out on the system that captures the national malaria surveillance data. You don't need to do an in-depth evaluation of any other system apart from this comparison that we mention here, and maybe a high-level overview of other systems that exist and whether they're integrated or not integrated with the routine malaria surveillance data. If you don't have DHIS2, you can extract the data from the national level and just standardized template into the Excel workbook That's part of the toolkit, and all the graphics and tables will be populated automatically, as well as a summary results table. At the service delivery level, you extract data from the national system and compare it with the source data from the registers by entering the 2 sets of data into the workbook. The tool will do an automatic comparison and flag any errors in the core variables, and will also give you levels of completeness and a summary results table. And you would take this case-based data extracted at the national level to the service delivery level and compare these cases in the registers, the case investigation and foci investigation forms. And we've also developed an algorithm to allow you to check if cases have been classified correctly. You start with what the case has already been classified as, and then you follow down the flow chart, looking at the evidence for each of the cases, and then answering yes or no, which will eventually tell you whether the case has been classified correctly or not. Finally, there's a question bank of questions to help you develop a questionnaire to interview staff at the service delivery level at the same time as doing the DQA, so we can understand why we see certain results with the performance. And so an example from the results of this questionnaire is here in Ghana, where we can see that the majority of respondents answered that they had problems with staffing issues and too much workload. And these are the reasons responsible for missing data in some of the areas. So at the end of every assessment, there should be a set of recommendations based on the findings. And these recommendations can be incorporated into the National Strategic Plan. And they can also be used to develop an action plan for surveillance system strengthening, where these recommendations are ordered and ranked by impact and feasibility. In the interest of time, I'm going to stop there. I would like to thank you for listening, and I will be available for the question and answer session later. Talk to you then. Bye-bye.
Right, thank you. Thank you so much. Thank you so much, Dr. Laura from the Global Fund. Molly Robertson.
Yes, hi. I am attempting to share my screen, but it doesn't seem to be allowing. Oh. I think now I can. Just one moment. Okay.
All right, Molly, if you're ready, all yours.
Okay, can you see that? Can you see my slides?
Yes, I can see it.
Okay, great. Thank you so much. So today I just want to go over some of the things to consider. As you know, the new funding requests are coming up for the new cycle in the Global Fund. And I wanted to make sure that we discuss with you what some of the activities are that are important and allowable under that Global Fund funding request, not only in the funding request itself, but as part of the development of the funding request. So I'm going to go over this with you quickly, and then we can talk more in the discussion and answer session about how this relates to some of the pieces under the great presentation by Dr. Anderson. So, for the new objectives for the 2023 to 2028 Global Fund cycle, I'll go through the others first, but really looking at ensuring optimal effective vector control coverage, optimizing chemoprevention, ensuring equitable access to diagnosis and treatment, and driving towards elimination and facilitating the prevention of reestablishment of malaria. The first one is the one we're going to focus on, which is really implementing interventions tailored to the subnational level using granular data and capacitating decision-making and action. So this is really, how do we drill down, find out where the problems are and take action, make decisions at a subnational at a very fine grain level. So what we're really talking about for the subnational tailoring or the use of granular data is looking at the local data, the contextual information to determine not only appropriate mixes, so what do you do where, how do we differentiate delivery strategies for optimal impact, but we are also, looking at ways in which that decision-making can be localized so that the information does not have to necessarily be gathered and analyzed, with delays, but can really be take action at the time. In terms of the national, or in terms of the funding request itself, we do not expect that every country will have what has been deemed full subnational tailoring plan. So this is often scenario-based with scenario-based modeling that happens after risk stratification. So you'd take all of the information you'd have, you'd do some risk stratification in terms of where you'd place your malaria interventions, and then scenario build off of that, depending on what the available interventions may be and what would likely be best in your context. We're not expecting all of these scenario built models to be part of every funding application. It really depends on the ability to have all of the other information in place, which many of you may have, but really looking at how to incorporate all of this work on risk stratification and scenario building into the activities that you have to prepare anyways. So looking at necessary reviews, national strategic plans, timelines as per your national planning, making sure that you're starting to build in some of these data activities, data reviews, and risk stratifications, an analysis of interventions that you have used previously into that process. Really considering what staffing and equipment is needed for things like malaria data repositories, data collection analysis, all of these program reviews. For the funding request now, really consider what you need to build out that funding request that is really strongly evidence-based and showing good, solid data. So whether that is needing to, quickly look at what your capacity is in terms of data specialists, data analysts under the SME team now, if there's any TA requests that are needed to send to either the WHO or to roll back malaria, identify critical gaps, ask for that support, and then highlight any potential bottlenecks between now and the funding development with your country teams to be able to help facilitate asking for some of that support. So really, when we're talking about, evidence-based decision-making or subnational tailoring, it's really, support for in-country capacity to look at tailored interventions, building up that data quality at the subnational level, ensuring that there is consideration beyond malaria epidemiology. So, I think all of us know that some of the solutions cannot be found just in considering epidemiology, but really need to be based on local contextual information. Delivering all these interventions in a people-centered manner, again, really focused on what are the contexts that are driving some of this transmission and how do we interrupt that transmission, and ensuring all of the commodities, monitoring effectiveness of that. So some of the specifics to consider in terms of eligibility in the grant are the creation and maintenance and use of data repositories. So really looking at how do you pull all this information together? Is it interoperable with other existing information? Are you able to draw from routine surveillance? One of the things that I think is really important in an elimination context is thinking about how to continue continue that surveillance system when the number of cases tend to drop. So what does that integration look like? So all of that can be considered. Introducing additional relevant data sets into malaria data repositories, again, really understanding the context. What kind of contextual information do you need? How can you build that into data repositories? How can you collect it first, but then build that into data repositories as well? And then continuous quality improvement, again, addressing the issues, activities to address data quality issues, but also contextual issues at a subnational level in as real time as possible is something that we would like to see and to fund. Activities to address data gaps, such as understanding what the barriers to access, again, as Dr. Anderson was presenting, what are you not seeing in terms of the surveillance system, and how can some of that be addressed? The short and long-term capacity building of national and district malaria programs, again, really looking at integration, building out that the data staff and the strategic information staff. In terms of malaria surveillance, specifically looking at HMIS systems and the funding for other surveillance activities. So just to get a little bit more specific, this is some of the same pieces, but I think one of the things that is often confusing is what is considered under malaria funding and what is considered under RSSH funding. So I have here both of them and what to consider for data quality and data analysis and strategic information. So really under subnational tailoring, under malaria, we're talking about malaria specific data repositories. So if that is a need, looking really at all of the different contextual information that is specific to malaria that needs to be drawn into a data repository that may be different from a data repository that is across different diseases or part of a larger system. Continuous quality improvement initiative. So how do you deal with the local problems as they arise and be able to continuously quality improve not just the data, but also service delivery. Understanding what barriers to access are and how that differs in different contexts. The short-term and long-term capacity building of not only national, but district, local staff. And then data management and analysis staff that is malaria specific and malaria-specific burden mapping. So all of that we would really want you to consider under malaria, under this process of sort of subnational tailoring and really drilling down to where the malaria lies. Under RSSH, it's a sort of pullback, and broader systems obviously very interrelated. So looking at what the HMIS and surveillance systems are through with a broader lens across diseases and throughout ministries of health. So how does malaria surveillance fit into those systems? How do some of the contexts of elimination look in terms of transition in this broader surveillance system? What are some of the issues around data governance, security, privacy, confidentiality, all of the pieces that are even more important as you start to get really specific in terms of case detection and digital systems, looking at the workforce and capacity building on HMIS across the board, digital health infrastructure. So obviously this is not just malaria specific, but looking broader. The civil registration vital statistics systems, the national data quality reviews and improvement plans, capacity building, program reviews, including EPI and impact analysis. So some of those broader program reviews can be funded under RSSH. And the setting up of surveillance systems and practices at delivery sites. So, really trying to move the surveillance system down to the locations where you find malaria. So the things that we're really looking at for intervention targeting include cross-border malaria surveillance activities, excuse me, and ANC-based surveys are a potential, looking not just ANC, but looking at different ways of being able to get information. So innovative ways to be able to get some of that contextual information that's really important, school-based surveys, subnational surveys, including lot quality assurance sampling. So, obviously with justification, but looking at ways that you can do some of these innovative surveys to be able to get more contextual information, as well as the broad household surveys, the DHS mix MIS that all of you are familiar with. And then really looking at if you need specific intervention effectiveness or cost effectiveness analysis, obviously, has to be well justified in terms of the necessity to spend money on obviously data gathering versus some of the implementation, but if it's needed, it's there. Development of epidemic monitoring thresholds, determining of changes in receptivities. Obviously, this is very important in a subnationally tailored look, really looking at that transmission. Malaria surveillance in targeted risk groups, vulnerable populations, which is obviously very relevant. Setting up of surveillance, sentinel surveillance systems, proactive and reactive case detection, epidemiological investigation of cases, contexts and focus of origin, and then development of guidelines and SOPs for epidemiological investigation. So that's all I have for you, and happy to talk more about how this relates back to some of the information that Dr. Anderson was presenting, and thank you.
Thank you so much, Ms. Robertson. Thanks a lot. So I will pass the Q&A session to Professor Mort.
Thanks, Paul. Remove the microphone. Thanks, Molly. We have Laura joining us this afternoon in session 2 for the Q&A. So obviously that was a recording that you saw, but we can take questions from Molly now. For online participants, if you raise your hand, and ideally if you can unmute, you can ask your question in person, but we'll take questions from in the room first. So if you'd like to ask a question, please raise your hand and then off we go. So any questions or comments for Molly? Yeah, so there's no hands raised. I'm just going to ask a question myself, Molly, if that's okay.
Sure.
Just to ask, what other dissemination events will there be? Because I know there's been some changes in the guidance from Global Fund about what countries can apply for. So in addition to your talk today, what other events are planned for the region?
Yeah, there are going to be a series of webinars. Those are mostly going to come out after allocation letters, which will be at the end of December. Hopefully those will be out. So I would just keep an eye out for that. But if there are any questions before that, I would just encourage you to, specifically on this, encourage you to reach out to your country teams, and then they can get in touch with me and others. If you have questions or concerns regarding building out that request and taking all the necessary steps to have strong data in your request, if there are technical assistance that you need for that, please do reach out. There's also the info note that you can find online already, and I would encourage you to go through that and see if, again, if there's any questions that we can answer from that information.
Thank you. And there's one quick question in the chat. You can see it, Molly. It's at the last slide, ANC-based survey and school-based survey. Do we need the intervention approach, or only surveying is good for specific activities?
Popo, I'm not sure I understand the question. For what we were talking about there for ANC-based surveys or school-based surveys is really focused on looking at that as a site for understanding parasite prevalence. And then as long as you have a good understanding of how that relates to, perhaps prevalence in your areas, as prevalence drops, that becomes more difficult. But it can also be a way to look at some of the intervention uptake, and depending on the area, depending on what kind of interventions are in place, doing some of that surveillance either through school-based surveys or ANC-based surveys can give you perhaps a better idea of things like coverage and health-seeking behavior in a more granular fashion than some of these large surveys. So it is really, looking at ANC and schools as a platform to be able to ask some of these questions to get at the data in a different way than you would necessarily with some of the larger community-based surveys.
Right, thank you, Molly. So everyone looks very happy in the room. There's no hands raised. So we'll thank you for now, and we'll move on to the next presentation.
Thank you so much.
Which is in fact me. Is the sound okay? Because I'm feeling the microphone's far away. Can you hear me okay? Great. So I'm going to introduce our breakout sessions, which is the exciting part of this meeting. So that's the part when you all participate. But I'm going to give you some background information to make it make more sense. You've heard a lot of great information from Laura and then also from Molly, and it's very closely related to that. So we're going to be looking at data quality dimensions and what the main challenges are we face across the region with the quality of surveillance data. And there's a broad definition of that I'll tell you. And particularly what those problems are and how we might be able to solve some of those problems. So we're going to brainstorm a bit together in groups. Okay, good. So the objectives of the session, I'm going to tell you about the 6 dimensions of data quality, which is probably the most commonly used set of dimensions. And then you'll be randomly assigned, totally random, into groups. So you'll all have to pick up a number. When you leave the room, you get a number which tells you which group you're in. And we'll be going into different rooms, into groups to do this work. For people online, we're going to split people into 2 groups in Zoom. And it's always fun using technology to do this. We have breakout session 1, which is for 1 hour. So there'll be introductions. You'll get to introduce yourselves in the room, and you'll go over the topic again, which I'm going to tell you about now. And then you identify, the goal is to identify and describe specific challenges for measuring malaria surveillance data quality, and what the challenges that are faced with suboptimal quality. And then to confirm what those top 3 challenges are, to then present back to the group in a plenary. So you'll come back into this room and then share what you think the most important challenges are. And breakout session 2 will be after lunch. So you'll introduce and recap what the challenges were from that group, and then discuss and find some potential solutions for those challenges. So trying to identify some solutions for the challenges identified in the morning, and then summarize the top 3 challenges and solutions, and to identify a speaker to then present all of that back at the end. So the presentations will be at the end of the second breakout, when you'll present both on the challenges and also the solutions, and we'll be looking for volunteers to present. So we have a facilitator for each group. The names are up on the top right. My face is in the way. But Steve Ebner is the first group. Group 2, Sazid. Group 3, Jade. Group 4, Greta. And Group 5, Chawarat. So you've seen different versions of data quality dimensions, and you'll keep reading different versions from different organizations. There's lots of ways to classify data quality. This is probably the most widely used. So there's a International Data Federation and Data Access Management. There's various organizations that use these same dimensions. So I've adapted these slides from information from the UK government, who use it across all of government. As many other countries do the same. What Laura presented, a lot of those different dimensions fit within some of these wider categories. So the first one here is accuracy. So accuracy being when data reflects reality, and some examples I've put like the correct name or address, or the correct test result for a person. So it's likely that problems with accuracy occur at the time of data collection. So you have to look closely at each data field to see if the values look plausible. And one example that's commonly cited is if the age of a person is clearly silly, like 150 years, then it's not accurate. So there are some simple ways of spotting, but sometimes this can be quite subtle. Real world information can also change over time. So it could be accurate this year, but it might not be accurate next year. So it can be quite challenging to monitor. So for example, a change in the population size of a village, or even a village may appear or disappear from one year to the next. That makes it difficult to calculate API, so incidence divided by population. So you have to regularly review the data that might change over time. If you have highly accurate data, then your data analysis is more trustable, and it helps with better reporting and confident decision making. A couple of examples here. Can you see that? Yeah, you can. So this is the age 150. Clearly, that's not realistic. Nobody can be that age. Here you've got a map of locations of villages, and there are villages here that fall outside of the country border. So that's clearly inaccurate. And then here on the bottom right, this little video is of a a village in Bangladesh, which is growing over time. The number of houses keeps increasing from year to year, and the population is growing from one year to the next. So this is the main one that Laura talked about, which is completeness. So really your data is considered complete when you've got all the data that you need for a particular use and it's available to be used. So it doesn't necessarily have to be 100% complete. It's about knowing when it's complete enough. So the critical data, that it's more important that it's complete, and some data is less important. It might include, for example, missing variables. So there might be no age recorded for a patient. It might be a missing test result. Could be missing information in a report, like the number of RDT tests done, or location information like the name of the health center or the district, or even a missing report, the complete report. So there's different levels. Maybe missing the number of tests done, and that can result in an ability to calculate the test positivity rate. If you're missing a monthly report from a health center for 1 or more months, then you get an underestimate of cases. So there's consequences. And it's important to assess whether the data set meets the expectations of what's needed for that particular item, whatever that might be. And this helps understand if missing data will have an impact on its use, and then the reliability of the insights from the data. So it's not the same as accuracy. So you can have a complete data set, which could have incorrect values, or an incomplete data set with correct values. You might have full information about malaria cases, but it doesn't necessarily mean the information is correct. So some examples here at the top right, we've got, this is another example from Bangladesh. We've got a district with some sub-districts, and then there's a missing population count for that sub-district. So for that sub-district, you can't then calculate your API. That information has to come from somewhere. Here's the health facility list. So for that particular health center in Bangladesh, you know that there's a building there, but whether there's actually a health service provided at that building, whether there's any staff there or a functioning service, isn't recorded. And at the bottom right here is another example, this village map where you've got 12,000 villages, but there's only 7,000 of them that have been located. The rest of them are missing GPS coordinates. Then you can't use those for mapping. The third one here is uniqueness. So this is essentially measuring the number of duplicates. Laura mentioned this one as well. So data is unique if it appears only once in your data set. And there's some examples like the same malaria case can be recorded by a village malaria worker, and then they may be referred onto the health center and then recorded again. They may appear twice in the same database for the same episode and then double counted. So you can also have a duplicate record, even if some of the fields are different. There maybe they have a birthday in between, so the age changes, or maybe they state their address differently each time. So the matching is not always so straightforward. Sometimes the spelling is also different. So duplication is particularly a risk when combining data sets, and different parts of the surveillance system, like hospitals and community workers, for example, which collect data separately, they're more difficult to combine and to remove duplicate records. But yes, the more that your records are unique, the more trust there is in the data. So here's an example, just 2 different records with different unique ID numbers. So this particular person has only had malaria once, but they've been counted twice, and they have 2 separate ID numbers in the system. So you add up the numbers, you get 2 instead of 1. Number 4 is consistency. So this is when data values don't conflict with the other values in the record or across different data sets. An example here is the number of RDT tests being less than the number that are RDT positive, which is clearly not possible. Everyone that's positive must have also had a test. You could also have different names for the same place, like the same village, in 2 different data sets. Consistent data improves the ability to link those data together from different sources, and that in turn supplements the data set and increases the use of it. So when you can combine easily, here's some examples also from Bangladesh. We've got different names for the same village. So these are just different versions of the same name, but when they're recorded in the database, they appear as different strings of text. So they appear to be different villages when they're actually the same. And here's another common problem where you're entering the name of an area. So in this case, it's a large part of Bangladesh, a division, very large administrative unit with a different spelling. So Chittagong versus Chattogram. So they've actually updated the name to Chattogram. And Barishal and Barisal, they're just different spellings of the same unit, but the database will record them separately and they'll count them separately. They should all be the same. So number 5 out of the 6 is timeliness, which is the other very important one mentioned by Laura. So this indicates whether the data is available when expected and when needed. So it means different things for different uses of the data. And I put some examples like responding to outbreaks. You want to know very quickly what's happening. So it's critical to have the number of cases as quickly as possible to spot the outbreak early so you can intervene and try and stop transmission. But for things like annual reporting to external organizations, perhaps it's acceptable to have a longer time lag before you get your data. So bednet coverage, if you're reporting to WHO for the World Malaria Report, for example, maybe you don't need to know tomorrow. You can have a delay of some weeks or months. It's time to clean and collate that data. Data quality can also improve over time. So a delayed reporting in remote areas, sometimes paper records have to be carried by hand and there's a delay before you know about your case. So when there isn't electronic reporting, maybe there's a few days or a few weeks before that report reaches someone who can then enter it into the database. And it can also decrease over time, so your quality may get worse. So as we've mentioned, a population account can change or even an administrative boundary can move over time. So when you first collect your data in a particular year compared to the next year, there may be a difference in the geography. So you're trying to match your cases to an old geography, then your data quality has gone down. It's important that you have timely data because it gives value to the information, particularly for time-sensitive matters. And timely data, as we've noticed during COVID-19 pandemic, it made healthcare provisions a lot more responsive and it saved lives. Very clearly important that there was timely, accurate data during COVID. There's been quite a lot of work to try and improve systems that were funded through COVID as well, which I think has also helped for malaria. There's a couple of examples again at the bottom. So we've got a master facility list here where there's a community clinic that's not even in the facility registry. So it's not in the list of facilities, but they're reporting cases. And then here we've got a change in the number of villages in an area over time. So there are new villages appearing from year to year in this particular sub-district. That's also a common issue. Finally, we have validity. So this is the extent to which the data conforms to an expected format, type, or range. So an example could be if someone's microscopy negative, but the parasite species is listed as P. falciparum, the way that you write P. falciparum in the database also matters if it's PF or the word falciparum. There's usually a fixed way to do that. Or if a month is recorded as a number, perhaps it's a number from 1 to 12, but someone types in the word for the month. So there's a particular format for data. So having valid data means it can be used with other sources. It also helps to promote smooth running of the automated processes. So if you've got DHS2 or a set of code or an interface built on these different fixed formats. But you can't take for granted that if the data is valid, it's always accurate. For example, a system that stores a patient's age, if somebody types in less than 5, that may not be a valid value, but someone may be able to enter that because the cell isn't locked to only accept a number. A value of 5 for a person's age would be valid, but it's incorrect, of course, if the person is actually 3 years old. So just being valid isn't enough on its own. So here we've got a couple of examples of invalid codes in a data set. So sometimes there's an administrative unit code or a health facility code, and there's a particular format for that code. And normally for those codes, there should be a fixed coding scheme. So if it's a village or a health facility, usually there's different parts of that code, like indicating which province it's in and the type of facility. So for the exercise, for the breakout groups, we've split surveillance data, and as I've said, it's a broad definition of surveillance data, into 4 different categories. So we have non-disease data, which is, for example, population count or administrative unit list, village list, health facility list. Could be human resources like number of village malaria workers. Could be climate data. Could be logistic information like transport or drug stockouts. So that's the non-disease data. Intervention data, for example, mass drug administration or targeted drug administration. It could be the coverage or the timing. Chemo prevention, bed net distribution, IRS, etc. So that's the intervention part of it. And then we've a category of mosquito data, which would be mosquito collections or insect design resistance data, etc. And then the biggest that everyone talks about is case data, which would be passive surveillance, active surveillance, reactive case detection. For example, 137 could be drug resistance or data from different sources like the private sector. So that's how we split it up. So we have these 6 dimensions and these 4 categories. And we are going to take a break before we do that. So there will be a number to put you into a group that you should get on the way out of the room. And there's coffee and snacks outside, I hope, anyway. And who's giving out the numbers? So time for a break. And we're going to go to the rooms at what time?
All right, we're gonna have 15 minutes breaks for the coffee. It is already outside in front of our meeting room. And before you go, you will go back and then Marina is standing there. Yeah, over there. And then before you leave the room, you pick the number in a glass of bowl. And then we're gonna have 3 meeting rooms on your left-hand side. The 3 meeting rooms. So we're gonna split you guys into 3 rooms. Okay, Marina, are you ready?
And they're downstairs, aren't they? They're on the next.
Yeah. And for the lunch, we're gonna have we're gonna have lunch at a JS restaurant. I think it's the same place for our breakfast this morning. Yeah, it's the same place. Okay, we're ready now. So we're gonna have 15-minute breaks and see you in the group discussion. Thank you.
And the last one is the population, especially for the forest score. They are quite dynamic, and we have less accurate surveillance data in that group. So we should do research more and to understand of this high-risk subpopulation in order to get used to them and increase the accuracy of this population. But in the meantime, we should also provide them the personal protection to prevent malaria transmission to other populations. But at the end, we should know more and do research more to get to know their nature, able to get the accuracy report from this population. And that's all for our group. Thank you.
So please give a big applause to Dr. Chavaran. He's a representative from online group 5. So we're gonna have another online group, and our facilitator is Dr. Greta.
Hi. So our group representative is Abdul from Pakistan, and he's going to present for us. Abdul, you here? Can you check whether or not you're muted? We can't hear you. So I'll just present. We identified a few challenges. So first of all, there was a problem with consistency and timeliness of case data. Specifically with the multi-level data aggregation. So there were different levels: health facility, district, provincial, national level, DHIS, different sorts of systems being used, and therefore different difficulty with consistency. And there was also limited internet connectivity for the data collection. This was a problem because it delayed the decision of the programs and interventions, especially when the resources such as entomologists are limited. And if they had the data on time, it would help to manage outbreaks. So for example, in Pakistan, there's a 1-month delay in reporting, and ideally they would want this to be within 48 hours. So we identified that it seems to be in both countries that DHIS2 is being implemented. So in Pakistan, this has been introduced in 60 districts supported by the Global Fund. But there is still a difficulty whereby it's not all of the districts and they're slowly being implemented. And
sorry,
you still use paper-based collection. So hopefully the plan is to.
Hello, Dr. Geeta, I am came back due to connectivity issue. There were now I am came back to online.
I think that's him, probably. Is that Abdul?
Yeah.
Yeah, so maybe you can continue.
Okay, thank you very much. Good morning, good afternoon. I think so. There's a afternoon, and this is Abdul Hamid from Vector-borne diseases, Hyderabad, Pakistan. This group we are presenting group 4 online Bhutan, Cambodia, and Pakistan. The challenge number 1, type of data indicator, case data monthly mortality case notification at health facility level. There is a dimension of data quality challenge, consistency, and timeliness, but essentially it is a multi-dimension. Nature of the challenge and where it is found, multi-level data aggregation, which are facing in those countries at facility level, district level, at provincial level, and also at a national level, and DHI system used. And another issue is challenge is internet connectivity to data collection at health facility. The important challenge, how does it affect decision making? This will delay the decision of the program to perform intervention in the areas in time, especially when limited number of entomologists are in place. And another is having the data in time will help the program to manage outbreaks in Pakistan, e.g. For example, we are getting the data after 1 month delay in reporting. Ideally, this should within 48 hours for the malaria outbreak investigations and response purpose. Then after challenge currently being addressed, are there any initiative project in the Asia Pacific? In Pakistan, we are using DHIS2 in only 60 districts supported, introduced by in Pakistan 2019 onwards, which can capture all the required data and indicators by the WHO. But this is entered at district level only the moment health facility is still used paper-based data collection. The future plan is to prepare a health facility to enter data onto the DHIS2 using mobile phone or other device and enter them onto DHIS2. And what are some other potential solutions to addressing these challenges, which are more training and capacity building and technical support currently is required. And we are depending on only one donor, which is Global Fund. And also we have a technical partners of the WHO and other partners. APMEN could provide support for our country and provide and improve internet connectivity, health facility level. It needs improvement in the connectivity for the far-flung areas and also hard-to-reach areas. And other provide staff tools like a computer, laptops is preferred so the data can be easily accessed by the user and trainings to collect and reported data. Please go on second page. Thank you. Non-disease data population, data logistics, dimension of the data quality challenge were accuracy. We will discuss the issues and for other countries also share their experiences, and currently they are using which tools are being implemented there. So we, Dr. Geeta has summarized the points in this template. Nature of the challenge and where it is found: incorrect of RDTs and drug used at health facility, mismatch between stock and reported, not counting and reported properly. Why is this important challenge? How does it affect decision making? Yes, definitely. If we have a proper information is not available, then we could not plan for the decision making, for the budgetary and resource allocation for the future, and the cope of the situation of the malaria and other vector-borne diseases. That the hinder in the management of stock health facility when the number of cases is low. Reporting accurate data will help manage the stock and reduce expiry of the stock. Because if we have available the information regarding stock situation where the on the disease based, then we can manage the stocks equitably. Otherwise, it could be the chances of the expiry of the stocks. Then after, and other area is the challenge currently being addressed. Are there any initiative projects in the Asia Pacific? Yes, there's incorporating about data entry in the system will also help correct the reported data. As the Bhutan is hello, did you hear me?
Yes, we still hear you. You can
Yeah,
continue.
okay. There is a connectivity issue. Yes, the Bhutan has incorporated non-disease data in DHIS2 to be reported on a daily basis, including data on supplies such as RDTs, drugs, and non-reporting commodity will also need to be entered. 3, case data from private sector in Cambodia and Pakistan. There's a dimension of data quality challenge is completeness, and the private sector not allowed to treat malaria, but presumably there are cases that might be detected at a private sector. There should be data input from private sector in the database, and not being able to get private sector data hinders the program to report the real API data in the system in country. And the challenge currently being addressed are the initiative taken by the Asia Pacific Group. Healthcare Commission, currently government organization is working in province and also in other province of the Pakistan. However, mechanism needs to be established at the national level for sharing data from private sector at all levels, bottom to top, because this is the missing area which are we are facing the most the challenges from private sector and issues also. Potential solutions for addressing the challenge. There is a legislation for requesting data from private sector is crucial, need to be enforced at all level from the central or national level to the provinces. Please, next. Dr. Geeta, please.
All right, thank you very much, Dr. Abdul Majid. No?
Dr. Geeta, I would pay, this is honor for me, and my mentor is sitting lying with you, Dr. Mushtaq Ahmed Shah Saab from Pakistan, Deputy Director General Vector-Borne Diseases. I want to pay salam to sir, and other our seniors and other country colleagues are there. Thank you very much. Assalamu alaikum, sir.
All right, thank you very much for presenting on behalf of the group. So next we have group number 1, Steve's group. I think we have presenting on your behalf representatives from Laos, PDR. We have Dr. Gao and Dr. Odai. So I don't know how we'll split it out. Nongbiu, you'll be sharing the screen and you can present whenever you're ready. Go ahead.
Good afternoon, everyone. From the group 1, I would like to present about the 3 challenges. The first challenge, case data, and second challenge, accuracy, and the third challenge, competency. The first challenge, case data, nature of the challenge. The first effectivity of challenge across data quality each dimension of level need to find the scale as well as the national level data, right? And too many parallel platform for the case data entry, like from partner, from CSO, from government, we entry data like a parallel. This is a challenge for us, and then it's difficult of the platform for the operational, like a community level or health center level. And important challenge, basic of intervention, the monitoring and evaluate. This is very, very difficult because the data almost we collect in the community level and then send to the health center, send to the district level to entry, and then we should monitor and evaluate to know the quality of data. And for the outbreak detection, this data really important to support. We have the plan to like decision to make policy or support like material also or anything to make the plan go to the respond to outbreak. And challenge currency, the private sector project like GEMS, submit region, eliminate of malaria talk, the surveillance, Laos, Vietnam, and Myanmar. We we do the private the sector this, and then the Cambodia have the pilot to use the like a finger print to the address unique the record. For the second challenge, like accuracy, the first general of challenge, lack of master list of the quality. For example, the name of village and sub village chain, we cannot like a chain every day, every year, and we can adjust like the number of population in that area to calculate, and then not on the population group coverage, mobile migrant population or foreigner or military also, and inconsistency between the paper-based and electric sometimes different, sometimes that is same data, and then the projection on data also this, and important challenge, foundation element to ensure the quality of on the indicator, need for design the making planning. This is really important for policy marker. And challenge currency, the global fund, global health facility data initiative and usage, and global fund also investing in the health system and health information system to strengthening. And the third challenge, competence, misunderstanding and miscommunication, what need to be the report, especially the across level, and insufficient supervision for the staff doing the report. Like a supervision have the limit time or limit budget sometimes, some area, because we cannot go in any health facility to monitoring, and sufficient supervision for staff doing the report also, lack of incomplete denominator, and lack of quality population data, like, and master it also. And important challenge, outbreak detection also, and provide the denominator with the basic of the intervention and avoid the gap in surveillance coverage, difficult to analyze or interpret. And challenge currency, in Lao PDR, the Ministry of Health of established the National Center for the Health System. Three challenge we can solution like this. The first, invest in the workforce to be trained about the quality. We have the training for the health facility or key person to integrate data, and to promote the certificate, and like awareness of importance of data, like the quality and management for the listing the malaria eliminate, maintaining the zero case, and the need for the having access to necessary resource, and then dedicate specific resource for the data auditing and center capacity for the data management across the program, include the National Malaria Control Program, and then cross program approach to improve data quality, and defining minimum business and functional requirement of the ideal information management. Yes. This is from group 1. Please, member from group 1 can add more if another have the question or just guess for group 1. Thank you so much.
Do any other members of group 1 would like to add to what Dr. Cao has presented? All right, with interest of time, I'll move on to Sajid's group. So I think we have Dr. Kinley from ANU presenting on behalf of the group. We'll just give them a second to share their screens.
Good afternoon, everyone. So I'm presenting on behalf of Group 2. Just to give a summary that all of the three main problem that our group identified were completeness, timeliness, and accuracy. So I will describe on this, and that all of those related to the case data. So the issue of, I'll now describe what was the issue underlining or underpinning the completeness. So it related to the size of countries. Some countries, some areas were far away, and they did not have resources to submit the report on timely basis. And there was also an issue of patients visiting to private health sectors, and then there was no system that in place, so that cases were not reported to the national surveillance system. And there were the other issues relating to missing certain groups, particularly pregnant women. That when they were diagnosed, they were not captured, or another group was children under 5 years. And then other issues that we identified were the surveillance report did not have adequate information, such as treatment regime, and going on with the completeness, because there were multiple reporting systems. Just to give an example, there were, I think, parallel system like MIS, Malaria Information System, and DHSI too, and they were not really integrating. They were not talking to each other, and then this led to some kind of differences in data, and this really, as a consequence, affected the completeness. And other probably relating to recording, we are missing of very important informations, like when was the time of onset, date of onset, particularly date of onset, and if it was like imported malaria, where were the sources of infection. So some of these were missing. And how these challenges were addressed, of course, the list was so long, we couldn't dwell on all of those, but a few important case studies were reported from 4 countries: Bangladesh, Cambodia, Pakistan, and Indonesia. So I will just briefly describe what they did, very fantastic things they did to solve some of the problems. Just to give a issue on the, unable to report submit the report on time from a very remote places. So in Bangladesh, they are now using a SMS to send it to a higher level whenever they have the mobile network. As a result, I think the reporting has, the completeness has improved. In Cambodia, they have, very interestingly, they have solved the issues of underreporting from private health centers, which was prevalent a few years or last 10 years ago. So they did a very important sort of nationwide program to train all the private health sectors to diagnose, test, and then make to report. And at certain point, when the cases were low enough, they just stopped, or they just passed a law saying that private health sectors, private health cares cannot diagnose and treat patients. So there was a passing of law, and as of now, I think all of them go to the public health facilities, and they are able to really capture it. In Pakistan, in the group 2, they said that there's a lot of gaps, so they really thought that building a capacity would solve this problem. And another interesting case study from Indonesia was they had also a big issue of not the private health sectors not reporting to the national surveillance system. So what they did was they started to sort of intensify the private health providers by giving them the anti-malaria drugs. So when the patient goes to them, they can get the services, but they don't charge for the drug. But because they get the drug, people go to them, so they really encourage. And one of the conditions is that they report these cases to the surveillance system. So and if they don't report, they don't give the drugs. So this is how they have addressed this. And I think this is a very important system. And in conclusion, in the last row, we said that probably one is a political commitment like Cambodia, where you pass a law saying that, okay, everyone should go to the public health center or report all the cases that come to you. Going on with the timeliness, I think most of this has been touched by previous groups. Nevertheless, we will also touch a few here. That one of the reasons timeliness was it was paper-based. The current system is in most of the countries, whether particularly those who have used the DHSI2, it's partly being done on paper-based reporting. As a result, there's a delay of getting report on time. And this is further aggravated even when you have a system of using apps, when there is the network connectivity issues. I think this resulted in delays. So what is being done in our region? So we have again three interesting case study from Thailand, Bangladesh, and Indonesia. So in Thailand, I think they were using web-based system, SMS. But I think that their experience is SMS SIMs, or the information we give them for the health workers to put is too complex. So now they are trying to go away and make it a simpler form. In Bangladesh, at the present, they are using SMS. And I think they are moving farther away from that. And finally, in Indonesia, I think they are also training the health workers at health centers like midwives. And the overall conclusion that we came to in this how to improve the timeliness is in like a case of example, Bangladesh, they are really trying to go for one system and then trying to really integrate even the SMS into the system. And going to the final area that we thought was important were accuracy. And similar to the timeliness, I think one of the culprit was using a paper-based reporting, where there were some, when they're recording, there are some errors were being made. And the two important issues that came up were the mobile population and migrant population. So we may not be able to capture them, so we are not able to get the accurate data. And last, not the least, is the submicroscopic parasitemia. If you are using the routine, the regular currently used diagnostic tools like microscopy and RDTs, the submicroscopic parasitemia may not be detected. So even though reportings are coming, if you are not able to get to all the cases, so that can also lead to a inaccuracy of our data. So what are we doing in our region? As I said, in Bangladesh, so they are trying to do away with paper-based reporting and going for web-based reporting, which is very interesting. And in Thailand, as I said earlier, I think they are going to make the apps reporting form very simple, so that the health workers or field workers can submit the report on time and accurately. So this is what I have on my computer and what I've noted. So I'm happy for our group to supplement anything that I've missed out. Thank you very much.
All right, if there's anyone who's in group 2 who would like to add to what Dr. Kinley just presented, it's now or forever. Otherwise, I'll move on to Jade's group, the last group. And I think for us, we have Dr. Win, who came up here with me, Dr. Win Han. Jade is all the way over there. She can
So on behalf of our group, then I would like to present our group finding. So first of all, then we have a case data. And then the first issue is the uniqueness, because for example, like in Solomon Island, there are different forms for the malaria. For example, like one OPD register, and then one RTG register, and then one microscopy register, and then sometimes it end up entering into different database. So it's more like a duplication of the data. And then the other one is the repetitive data of case. Thank you. Repetitive data of the case record, which is issues in the data at the health center and district is the same. So the other issue is the different system of being developed and different implementing partner present to NMCP. So this is really a kind of issues in, especially in the Southeast Asia, in terms of the uniqueness. So many organizations develop many reporting system or the reporting platform, and then these data are recorded and reported in the different platform. So it's difficult to integrate. So this is one issue. And this is at the organization at the national level. The other issue is the differentiation at the volunteer and the free level. For example, in some of the country, all the organization want to assign malaria works to the volunteer, especially for the recordings and reporting. So the problem is that one volunteer in a village work for many organizations. Sometimes they share the data between different organizations. In the worst case, then they report the same data to different organizations. So this is an issue. And then the other issue is duplication in the referral process of virus malaria. So sometimes, especially in Laopedia, the forms the forms filled by the village malaria worker and then submitted to the health center. Sometimes they forgot to record it, the case. So they also enter the case again in the health center. So something like this. So why is it important challenge? Because it is in accurate representation of the case burden and being able to follow individual case data. So as a solution, what we can do is to use the electronic data recording and reporting system in these malaria endemic country. And we also understand that electronic reporting system is not the magic bullet, but at least it can solve a lot of the problems of the data duplication. The other good solution would be the unique ID system. So we have been discussing a lot about the unique ID system in the malaria program, because in some of the other programs like the HIV program, they use the unique ID for each patient. So if we can develop this kind of unique system, then we can link different database and different data set, so that at least we can do the longitudinal data analysis for the malaria data. And how can I go to next? Okay, good. Okay. The second issue that we discussed is about the timeliness. So for the timeliness issue, I'm not going to go very detailed because all the other groups have already presented about the challenges of the paper-based reporting system and the electronic reporting system. This is across almost all the Asia Pacific country. So in Asia Pacific country, then many countries are still using the paper-based reporting system, but some country has changed to the electronic reporting system. Either we use paper-based system or electronic system, it has own unique challenges. For example, in the paper-based reporting system, definitely we will face delays because someone need to bring the paper record to the computer system to enter into the computerized system. However, we can shorten the delays of the paper reporting system by providing incentive and by providing transportation assistance, or sometimes we can bring the data entry and analysis unit close to the village level. Again, if we use the electronic reporting system, we can solve these kind of issue, but we also need to provide support for the electronic reporting system as well. So one alternative solution is that if the Ministry of Health develop the comprehensive electronic reporting system, not only for malaria, but also for other diseases. In this way, then many departments in the Ministry of Health will invest in the electronic reporting system, and then the electronic reporting system will develop quickly. So the last issue is about the data accuracy. So the issue is that no updated information of population, denominator at the village level. So this is also across many countries. This is because inaccurate calculation are based on the inaccurate denominator. So to solve this issue, then what we can do is that we can also ask the frontline health service provider or the village malaria worker to report the denominator, which I mean is the village level population data along with the reporting of the malaria cases. In this way, the village level population data will be updated accordingly. Or maybe in Lao PDR, one example is like simply normally simply frequently do the mapping of the population in the malaria endemic area frequently. So in this way, then the denominator or the population data is updated accordingly. And as an alternative solution, then we can build in more routine data collection system, especially in high barren area. So these are the issue that we discuss and solution that we propose. So if I miss anything, I would like to invite my group member to contribute and to add more. Otherwise, thank you very much.
So thank you very much. Thanks to all representatives from in sharing the findings from your group discussion. Before we move on to the next session, so I would like to inform that our coffee break will be at 4 p.m. I think it's not too late. Right, so next session will be the presentation. We have two guest speakers, so they are all here. And the first presentation will, she is Hannah Edwards from Rollback Malaria Surveillance Practice and Data Quality, RBM, SP, and DQ Committee. So, yeah, over there. Yes, please come to the podium. Come to me.
You did well to say all that without any coffee.
Thanks. I think it's a compliment. Your compliment.
Hopefully we can still keep energy levels high.
Yeah, right.
Okay. Am I close enough to the microphone? I feel quite high.
No, this is for me.
I'll bend down a little bit. Okay. So it's okay. I can bet. I can bet.
I can take it on.
You want to move it? No.
Easy.
Okay. 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 Height adjustments. Thank you. Good afternoon, everyone. My name is Hannah Edwards. I'm from Malaria Consortium, but I'm presenting today on behalf of the Surveillance Practice and Data Quality Committee. So it's very nice to be here with you all. So the committee was set up as a subcommittee of Rollback Malaria's Surveillance, Monitoring and Evaluation and Response Group, which goes by the acronym of SMERG. And it was set up to improve the visibility and coordination of surveillance and data quality projects. And so some of you might know Arantxa from her time in the region here. She's one of the current co-leads, along with Dr. Kendrino, who is director of the NMCP in Mozambique. But the committee has 38 members at the moment across 22 countries. And the membership consists of NMCPs, implementing partners, donors, and academia. So it's really trying to bring all of these different partners together to create a forum for discussion and new initiatives. And so the main objectives of the committee are to disseminate information on implementing partners' projects in surveillance and data quality, and to document or learn from their implementation and the advantages and disadvantages of the different projects and different tools being used. And then from that, to dynamically track the projects over time in a form of a dashboard, which is what I'll be presenting about today. and also to identify the needs of the NMCPs for surveillance and data quality. So we can check whether NMCP needs are being fully met by implementing partner projects and supported. So one of the first initiatives of the committee was to attempt to do a landscape mapping and to track implementing partner projects in surveillance and data quality. And so to realize that, a questionnaire was developed last year and distributed to implementing partners, and a landscaping analysis was conducted based on that. And this is what the questionnaire currently looks like. So partners can put in the title of their project and which country or countries the project is working in. And then they have the opportunity to upload any publicly available documents or website related to the project. They can state whether the project has a main focus on surveillance and data quality, or also we're capturing projects that might have a broader scope in terms of activities, but have certain pieces that are acting on data quality or surveillance. And then they can share focal points and project start dates. We also have various themes that partners can select that the activities are based on. So these relate to case surveillance, data quality, data to action, and governance themes. And then depending on which themes are selected, you can do a deeper dive into the certain activities that fit within each of those themes. You can list collaborators, information about which level of the health system the project targets, and which sector of the health system, so whether it's public sector or private. We also ask about the donor landscape, and people can, if it's publicly available information, upload the budget for the project. And then they can also share documents where advantages or lessons learned from the project can be shared and disseminated further. And finally, there's a section just to highlight any dissemination events or anything upcoming that you might want to put out to a wider audience. Okay, so this is the timeline of the implementing partners tracker so far. So the questionnaire was built and reviewed by the committee in August last year, and APMEN Secretariat was consulted and approved, and the questionnaire was then disseminated to member countries, including 9 countries in the APMEN region. And implementing partners uploaded their projects, and up until October last year, they were included then in a landscaping analysis, and that landscaping analysis included 21 projects, the results of which were presented at last year's SMERG meeting in November. From those projects, an interactive dashboard was then developed and went live earlier this year. And we're currently now in a period where we're trying to encourage partners to update their projects, to upload new projects, so that we can conduct a second landscaping analysis. And at the moment, it's up to 37 projects. So this is what the dashboard looks like. Currently, we have 37 projects across 50 countries, 15 implementing partners and 14 donors. We map where the projects are. We also list them by theme. And you can also do a deeper dive into the implementing partners. So if you select on one of the implementing partners, the table at the bottom will zoom in on their activities. And you can also zoom in on certain countries as well. So the aim is really to have a better idea of what partners are doing where. So the questionnaire is open for people to upload their projects at any time. But as I said, we are doing a bit of a drive at the moment to get new projects uploaded, and any project included up until the end of the year will be included in the landscaping analysis conducted in January. And the results of that we plan to disseminate during a webinar. So the committee hosts malaria routine data in action webinar regularly, and that's on the themes of sort of data visualization, data quality, and the results of the implementing partners questionnaire will be shared through that. We also have a regular newsletter, and partners that have projects uploaded onto the dashboard are invited to write a partners corner where they can do a deep dive into a certain projects that they have listed. So we're really hoping that we can get more projects uploaded from the APMEN region. We have a few at the moment, but we don't cover all countries or all partners. And I'm sure there's some projects there that could be uploaded. And so any partners that would be interested in putting in their projects, we can disseminate the questionnaire today, and any questions you can let me know. Okay, thank you with that.
Thank you so much, Hannah. Thanks a lot. Before we move on to the next speaker, we will serve you tea and coffee right here in the room. Okay, before we fell asleep. I know the weather is so cold. I told the hotel room to increase our temperature now. So next speaker, Elijah Philip. Sorry if I pronounce your name wrong. So he's from Chai.
It's this, yeah. Hi, everyone. While this gets set up, for those of you who I have not yet met, my name is Elijah Philip. As was mentioned, I work for Chai. I'm an epidemiologist slash technical advisor with the organization. And today I'll be talking about identifying and addressing data quality issues, and just give a couple examples from some of the countries here in the GMS. Next slide. No, oh, there we go. Perfect. Okay, so just really quickly on what I'll go through, just some background on why data quality is important, which I think we all kind of know given the sessions that we had this morning. We'll talk a little bit about Chai's work with NMCPs and how we identify data quality issues. Then we'll go through two country-specific examples. We don't have time to kind of go through all of the countries in the region, so we'll just give some examples from Laos and Vietnam. And then lastly, just talk about next steps and key priorities from Chai's perspective. So I'm not going to dwell a ton on this slide, but as we know, poor data quality impacts the ability of country programs to make evidence-based decisions. And so as we had this discussion earlier this morning with WHO, and some of the key data quality issues or indicators that we would look at, like reporting completeness, reporting timeliness, or concordance, all three of these, if you have issues on any of these indicators, they're ultimately going to undermine the ability of a program to understand where transmission is happening and prevent them from responding in an impactful manner. Right? Potentially, those resources are going to be spent in areas where there isn't transmission or there's less transmission happening. And ultimately, the limited resources that the countries have for them to ultimately eliminate malaria are going to potentially be wrongly spent. So we want to make sure that we don't have major data quality issues before we even start thinking about how we address the epidemiological situation that's happening in country. So Chai does this alongside NMCPs and subnational programs in a couple of different ways, but the two that I wanted to highlight briefly in this talk are standalone pieces, these data quality assessments, which can be over the course of weeks or months and operate generally as a standalone mechanism. So talking about things like the WHO surveillance assessment or the processes that a lot of countries have gone through during the RI4E application right now with the midterm reviews or the malaria program reviews that happen every 3 or so years. And these are just standalone projects to look at where data quality exists at a point in time figure out why there are issues with data quality, and ultimately come up with a list of prioritized recommendations for how we address those. Another piece that CHAI does spend a lot of time kind of working on and thinking through is these more routine data review meetings. So every country in the region hosts some level of data review meetings, whether that's at a national level or subnational levels. We host them internally at CHAI. I'm sure a lot of partner organizations do as well. But just thinking about how we can get data quality indicators in front of people as much as possible, so we can think about where those gaps might exist and how we might address those. So there's kind of a bit of a cycle here. So trying to integrate into existing review meetings that are already happening, building out action plans once we identify what those gaps are in those meetings, and then ultimately responding to those gaps. And then working through this process on a monthly, quarterly, or semesterly basis. So one example I'll give from Lao, if you have questions, the Lao program is here and can likely do a better job of explaining exactly what was done. But as part of the midterm review, the Lao program integrated the WHO surveillance assessment pieces into the MTR that they were doing. And one of the pieces that has been analyzed up to this point is this question around concordance. So something we talked about earlier, looking at the distinction between paper-based forms that were reported at health facilities, the paper-based forms that the district level received from those health facilities, and then the data that's ultimately entered into the electronic database. So there's 3 pieces of information, and they tried to compare where there were potential gaps in that data or differences in the number of tests or cases that were reported. And then that data was then further disaggregated by province, by district, to understand where those gaps actually existed. This analysis is still ongoing, but this concordance piece has fed directly into some of the recommendations from the MTR, which will then feed into the RI4 Global Fund application process. Specifically, data quality is now going to be added as a key indicator to weekly provincial data reviews. Again, making sure that people are looking at this data as much as possible so that they can address gaps in data quality. And then building data quality directly into supervision visits. So instead of waiting for these routine meetings or these big kind of standalone projects, just making sure that we're all looking at data quality as much as possible and ensuring that all points of care are reporting data at high rates and in consistent manners. And then in terms of next steps, there's additional data quality indicators in that toolkit that are still being analyzed. But ultimately, once that is finalized, that will feed into updates to the burden reduction and outbreak guidelines, which are going on right now in Lao, as well as just general system improvements for the surveillance system in the country. And then shifting over to kind of a more routine activity that CHAI has been a part of in Vietnam, the government relatively recently in 2020 worked on integrating the standalone malaria information system, the MSS, into the National Disease Reporting System, the ECDS. And in that process of setting up this new system or shifting people to the new system, there's a lot of expectation that the data quality would be quite low. People need to get used to reporting in a new system and figuring out how it works, how they get their data in there. And so one thing CHAI and the NMCP worked on was a slide deck for us to review some of these data quality indicators at a regular interval. And you can see here on the slides, or might be a little difficult to see, but on the left, there are some slides comparing the previous month and the current month of paper-based reports versus what's in the ECDS. And initially, when this system was first launched, this is all disaggregated by province, there were some large gaps in certain provinces. And this allowed NIMPE to dig into which provinces were having these issues, ultimately follow up with those provinces and address issues that they were having. And then about a year later, you can see there's all about 99%, 100% concordance between paper-based and the electronic system. These slide decks include a lot more than just concordance data, and that's all that we're showing here, but there's all sorts of data quality indicators like the ones we discussed earlier around completeness and timeliness, but there's also epidemiological information, again, so that everyone is just looking at this data at a regular basis and understanding what the situation is in country and what needs to be addressed. These data review meetings that happen monthly with NIMPE and the IMPEs ultimately lead to a creation of action plans at the end of each of the meetings. And those action plans, NIMPE has done a really good job of identifying what action needs to be taken, who's responsible, and how quickly that action should be taken, and continuing to follow up with those action plans each time that they meet on these monthly meetings, which is why we've seen such great increases in concordance with the ECDS MMS in Vietnam. And as part of the data review, a lot of the visualizations that NIMPE helped design for those data review processes and tweak over the last couple of years have now been taken and integrated into the ECDS directly. There was a recent update to the dashboards in the system, which will allow staff at both the national level and the subnational levels to review some of those data quality indicators in a more routine manner instead of having to pull the data out and do this analysis on a monthly basis. We're still working towards adding in some additional epidemiological information here. The dashboards include a lot of great epi data, but because the reviews up to this point have been so focused on data quality indicators, there hasn't always been time to review in depth a lot of the epi situation. Also, because the data quality was relatively low when the system was launched, we had little faith in a lot of the epidemiological indicators. But now that that situation has vastly improved, we can really start digging in and looking into what is driving transmission in the areas that we're seeing cases being reported, and ultimately build response packages based on that data. And then just lastly, kind of next steps and key priorities. From CHAI side, generally, we just want to make sure that us as an organization internally, and hopefully governments and subnational teams, are looking at these data quality indicators on a regular basis and understanding where those gaps might be so that they can best address those. We also spend a lot of time working on policy processes and government. So things like formulating guidelines and making sure those data quality indicators are part of the indicator set that is reviewed as part of a midterm review or a malaria program review, as well as simplifying data entry. So I know we've talked about in some of our smaller groups about multiple reporting systems or collecting duplicate information on different forms. The more that we can simplify that, the less likely it is that we're going to run into some of these data quality issues around concordance or other indicators that we're seeing in some of the countries. We spend some time as well working on digitization and making sure that paper-based forms can then be translated into electronic information so that we can validate potential issues that are coming up in the system, which might not be found if we're just using paper-based. We can then aggregate the data in an electronic system and identify where those data quality issues might be, and again, figure out where we need to respond. We do support as well on capacity building and making sure that each level of that health system, from the national program down to the community health worker, knows what data is being entered into the system, why it's being entered, and how they can review that data to make sure that what they are submitting is of the highest quality. And lastly, that kind of leads into the sustainability and transition piece. So this hope that we can institutionalize these data review meetings or these standalone data quality assessments to make sure that programs are fully aware of where issues in data quality might exist and how to address those, so that, again, we can build packages of response that are fit for purpose and ultimately will help us reach malaria elimination. That's it. I don't think we have a bunch of time for questions, but feel free to reach out to me afterwards. Happy to chat with anyone if anyone has any questions on this. Thanks.
Thank you. Thank you so much, Elijah. Thanks a lot. All right. Before I hand over the Q&A session to Professor Richard, I can hear the crank sound outside the room. And I am sure that it is not the sound of silence, but heaven. So they will come here soon. They will come here soon and serve you at the table. So please, Professor Richard. Oh, yeah, the lady over there. Yes. So let's.
Okay, thanks to the speakers. We're going to take 10 minutes for questions, and including Laura, who I think is now connected. Hello, Laura. Can you hear us?
Hello.
Yeah, great. Thanks for a great talk this morning. It was well.
Oh, that's all right. Sorry, I couldn't be there in person.
No problem. So there's any of the three speakers, both from this session and also from Laura's talk this morning. If you have a question online, please either raise your hand or put something in the chat. And if you have a question in the room, please raise your hand and we'll get you to speak. Who was first? I can't see.
So from online first or? Okay, we have the, yes, please.
Thank you. I'm Hermawan from Indonesia. Can I asking to Laura, Dr. Laura?
Yes.
Yeah. Thank you for your presentation this morning. So I wonder about the gap between estimated case and real case from reporting. Our problem is there is a gap. The estimated is twice than the real case are reporting from the health facility. So my question is there any data validation or any method to know which one or which method to know whether the estimate is close to the real case in the field? Thank you.
Yeah, so I think if you remember from my talk, the different layers of the onion, what we're trying to do now is make our adjustments more transparent. And what we hope to do next year is to send each country a profile that clearly shows the different adjustments made for care seeking in the public and the private sector and reporting completeness. These data are coming from, so the care seeking is coming from the surveys, and all the other adjustments are actually coming from the routine data that's reported in the World Malaria Report database. Now, I also mentioned in my talk that these adjustments, they're made on a national level. So, for example, they don't take into account that if you have low reporting completeness in some districts, it doesn't take into account how many cases are expected at those particular facilities. So what we can do to get a better estimate is work with countries to look at this at a sub-national level. So ideally, what we would do is we'd make these adjustments at each district and then combine the final estimated cases together. So if this is something that you're interested in, GMP would like to work with countries next year to do these kind of adjustments at a much lower level to try and firstly get better, more accurate estimates of cases. And secondly, it will help countries to do exactly what you just asked and see exactly where the gap is. So is the gap really in the care seeking? Is it really in the reporting? Is it really in the testing, for example? So we plan to run some sessions in the new year with each region to look at estimates in general and how that's done. And then if countries request it, we'll work with those countries to do these estimates at subnational level.
Thank you. I think Carrie was next.
Hi, this is Carrie Lynch, for those of you online. I had a question. I've heard a lot about data quality, and I'm just going back to the Global Fund presentation on use. I'd be really interested to hear of any tangible examples of data use and discrete kind of activities around data use, because I would hazard a guess that even if the data quality is poor, once folks are having to use it, the quality would improve. So it'd be good to kind of just disentangle the quality from the use and hear a bit more about that. And then to the group work, I think it was Pakistan and a couple of other countries, just on the private sector data. I mean, this isn't new, right? So I feel like we're repeating ourselves over the years. But if you ask the private sector to report into a public system and that private sector aren't meant to be treating, what's the repercussions for the private sector? I think it'd be good to kind of think a little bit more deeply about what the implications are for that data collection and that surveillance in the private sector if we're really going to try and tackle this as an issue.
Hello, I have a question. I'm Abdul Hamid from Pakistan. Thank you very much for your presentation. And also as discussed, the AP analysis. I want to share my experience that the Global Fund team and WHO team were visited in 2019 and conducted AP analysis through GMP team of WHO and reduced the districts which were supported at that time by the Global Fund. But my concern is because there is no operational research is conducted and only we are going to get the desk review data at the provincial or national level, and we are planning for the decision without any operational research conducted, or also there is a private sector, as discussed earlier, one of my friends, that private sector data is also not a part of national level data. But this area also needs to be included in a GMP AP analysis for the disease estimations and upcoming grants. So this is my question. I want to hear from you on this.
Who was the question for?
For Hannah Edward.
For Hannah, did you say? Yes. Sorry, just asking if you can repeat the question. Hannah's here ready, but. Can you just say again what your question was?
Sorry, Abdul, can you repeat, please? I thought you were answering on the private sector. Apologies.
Okay, fine, Hannah. My question is that as you discussed that earlier, API analysis conducted by the GMP team in the provinces for the estimations, and on the basis of that, the resource allocations are decided by the Global Fund. The issue we were faced in our country, in Pakistan, there are GMP WHO mission visited in 2019, and on the basis of AP analysis, they have reduced the number of districts from Global Fund support. They said the API is reduced, and so now the Global Fund has drawn their support in these districts. But it should be on the basis of operational research should be carried out, and then it will be decided either these districts are continue or not on the basis of GMP model, AP analysis by GMP. So the private sector data is still a big challenge for us, and it is not captured in our surveillance system. So it needs to be incorporated in these data on the basis of medicines are expensed or used in the country other than government sites. These information also should be part of GMP AP analysis. This is my submission, and guidance is required from your side.
So Hannah, maybe you want to just comment quickly, but we'll also ask Laura for input.
Yeah, I think it might be more directed to Laura. But in terms of the partner activities that are presented on the dashboard, there are some activities that try to incorporate the private sector. And if you're interested in looking at what those activities are, you can go onto the dashboard and look at what implementing partners are doing and some of the activities, and that might give some ideas for the next round of Global Fund funding. But yeah, on the other points, maybe Laura is better placed.
Yes, please. I would be happy to answer this. Okay, so first, just to talk about the activities that are happening right now. So actually, as we speak this morning, somebody in my team who looks at the subnational tailoring of interventions is working with new updated data from Pakistan to do these kind of adjustments I spoke about at a subnational level. So what we're trying to do with Pakistan now is firstly, get better adjustments of the estimates of cases in these areas with the new updated data. The second thing is that obviously with the emergency situation in Pakistan and the floods that have happened, this actually occurred in some areas that were not previously supported by Global Fund. And there are rapidly increasing malaria cases in this area. So to raise this point might be a bit controversial if somebody from Global Fund is there, but in my view, I understand that the way Global Fund works is they have to prioritize certain areas of countries for providing support for treatment, diagnosis and surveillance if they have more cases. However, in the situation of Pakistan, I do feel that that's been detrimental to the country and their ability to be able to control malaria, especially when we have these kind of emergency situations. So what I would suggest is going forward, we need to think about, it's all about preparedness and response. These kind of disasters can happen again in the future. So we have to think about, how we support the country as a whole, not just supporting particular districts because they have more cases, but how do we help this country move towards elimination and control of malaria overall? And of course, that means supporting all districts in some way. And something, that's pertinent to this group that I feel very strongly about is that every country should have one integrated surveillance system. And in Pakistan, what's happened is we now have, some districts that are supported for surveillance and have a very good surveillance system with granular epidemiological data in real time, and other parts of the country where really we just don't know what's happening. So that's my point of view on that. I hope that I've answered your question. And if there is somebody here from Global Fund, I would like to hear, I would hate to think that some of the analysis we're doing in GMP is actually contributing to this ongoing situation in Pakistan. Thank you.
Thank you, Laura. I think Molly's not online anymore.
Thank you very much. And our senior mentor already, Dr. Mushtaq Shah Saab is there, and hopefully these areas are also in their notice, and it will be discussed in detail with all the team members which are there, and hopefully the APMEN, WHO, Global Fund will support our country to materialize these things, and which are facing the challenges. The support of donors is required to cope up the situation for the malaria control and elimination in country. Thank you very much.
Thanks, Abdul. So we're just going to do two more questions. One is Carrie's first question, which we didn't really answer, did we? Do you remember what it was?
I'd be really interested to hear about examples of use of data for decision-making at different levels of the health system, as opposed to just the quality bit. So disentangling the use from the improvement of data quality. And then the second was around the implications for private sector reporting into a public or an MIS. I think it's easier said than done, and there are lots of repercussions.
So if any of the speakers know examples for the first question, the data-driven decision-making.
Is that on? I think that I can't give specific examples, but again, on the dashboard, some of the partner projects that are listed do go into some activities based around trying to improve data use and review of data, as well as data quality. So yeah, I would recommend looking at that in the activities section.
And regarding the private sector, anyone speakers want to comment? No, heads down. Okay. So we have a question in the chat.
We have a question here.
For Elijah.
Brack.
We'll take Elijah, who's been there for a while in the chat. Just saying, when using, so this is Mahesh Podel. When using electronic system, I'm interested in knowing how and if quality dimension and their definitions were revised to meet changes in data collection modality. That's a question for Elijah.
There we go. Okay. Thank you for the question. I think it'd be great to have a little bit more context on exactly what is being asked here, but generally, I don't think the indicators in the NSPs were necessarily changed to accommodate the way that data was collected in the system. I think it would generally be the other way around. So the example from NIMPE and the ECDS, there was a recent update, well, relatively recent update to the surveillance guidelines to change technically how, for example, foci investigation and response is done. And that necessitated some changes that were done in the ECDS MMS to make sure that the system itself was able to collect the data that's needed for us to understand data quality and data use. So I think generally the way that countries have looked at it is changing the system itself rather than changing the indicators to fit how the system is able to collect the data. I hope that answers your question.
Great, thank you. And we'll just finish with the last question at the back from Brack.
I have one question to the Laura, if she is there. In the indicator, you suggested that the proportion of the cases that sought care within 24 hours of symptom onset, and then again, the proportion of the cases with symptom diagnosed within 24 hours. Is this in the routine reporting what you're thinking, and how we can validate it, because it's a kind of a care seeking issue?
Yeah, so these are a very difficult set of indicators. Currently, what we say is, so, you know, these are the ideal time periods to have people diagnosed and treated as rapidly as possible. But we recognize that there are limitations. And so when we do these assessments, we do say that these time periods can be adjusted based on country guidelines. So if you already have a guideline in place, you can adjust these indicators to measure this. However, the measurement in itself is difficult, because what we're really looking at here are dates. I mean, it doesn't need to be the exact date, but we need to first have the information, and secondly, have somewhere it can be collected. So we need to have a system either on the register or electronic system where we are able to enter those dates and then have the system do a calculation. And that's something that a lot of countries are not collecting at the moment, in particular around the symptom onset, which is very difficult. Because as I mentioned in my talk, it's also very difficult for you're relying on the information coming from the patients as well. So yeah, but these indicators are there because this is the ideal. So we want to try and move towards this. So the first step would just be trying to get the information, trying to collect this and trying to monitor the data quality through supervision.
Right, thank you. So we'd like to thank all three speakers again. Just a small round of applause. And I'd like to call our in-person speakers to the front because we have a little present for you. And at the same time, we're going to show a QR code for the tracker for the form that was presented by Hannah. We're encouraging people to have a look at this, and if relevant, please complete it. And please share it also with other organizations that are doing relevant work. So I'm hoping this QR code will work on your phone, or you can take a picture of it and use it later. We will always obviously be sharing all the slides from the whole meeting. So you will get this to take away. So we'll have a 5-minute break if people need to go out to another room to do something, and then come back and we'll carry on.
ฝ่ายเทคนิคข้างบนอยู่ไหมคะรบกวนเช็คจอได้ไหมคะ We're facing a technical difficulty, so we'll just let the technical team come and help us out with this 1 second. In the meantime, we can dance.
So in the interest of time, we're going to continue without slides. Wish me luck. The last session was actually to get your feedback and suggestions for what we've been doing as a surveillance and response working group. So at Moro, we've been hosting and running this for the last 2 years. There's about to be a renewal of the surveillance and response working group and an opportunity to re-decide what we focus on. So we're going to ask for your feedback on what we did the last couple of years. And there's a few things I'll just mention. One is there's been a monthly newsletter, which I'm hoping that you've been receiving, and that we were asked to disseminate updates on research. There's a research list of published projects, and then we've had people that have written particular projects that have given more information, so research highlights. We've been updating on project news for different projects around the region, and when there's new guidelines that have come out, we've highlighted them. And then if there's been a training event, we've put something in the newsletter about that. So that newsletter is meant to be open to anybody. So if people are not getting it, we'd like to know. And if you want other things to be in it, please tell us. So we have a survey that we're going to distribute to get your feedback. The other thing is we conducted a training needs assessment survey back in May to July 2021 of all the national programs and also consulted partner organizations. So the goal of that was to find priority topics for which we would need to organize training for national program staff. And from that survey, a few topics came out quite strongly. One was case investigation, another entomological surveillance, data utilization, data to action. And there are some specific categories underneath that. So we've been collaborating with the vector control working group, particularly for entomological surveillance training. So there's been training around that organized by that group. Leo's was here earlier. So also we've organized GIS training that came out as quite a strong topic lots of countries wanted. So we had a training series just the last couple of months delivered by Steve and colleagues. There's been some requests for support with how to write reports, and we're going to go into that a bit more in the coming weeks and months. Some interest in learning about basic mathematical modeling and a few other things. So we're planning to rerun that training needs assessment. We think the needs do change over time. And then there's also technical support initiatives, which we can work with individual countries to provide more extensive support. That's a relatively recent thing. So we just set something up with Bangladesh, with NMEP, to start a new project with a small amount of funding through APMEN. It's like a pilot for a specific need. And we are reaching out to other countries to see what other needs there may be around the region. In some cases, that support can be more extensive and funded externally, and there are other routes depending on the scale of what's needed. We've also been organizing tech talks, which is an APMEN name for when we invite speakers to present on particular topics. And we've been consulting informally amongst NMCPs and partners about what those topics should be. We had one on surveillance for anti-malarial drug resistance, one on data quality for elimination, which has led to that being a topic for this meeting. Improving malaria services accessibility with geospatial data was another one that we did. And then we've also had an exercise where we have a rolling list of regional research priorities, which is meant to be a list of what the research needs are for the region. So we've had a series of online surveys, and then in the last annual meeting, we also had a session on this. So we're serving the country partners and also the partner institutions, and also looking at how we can fill these gaps in research as well. So this information is being shared with funders, and also a lot of the partner institutions and APMEN, either they're able to do some of this research themselves, or they know the right groups who may be able to support countries with it. So we had an initial list of research questions that was brainstormed during the last AGM last November. There's been follow-up email invitations to people that weren't in the meeting but are members. And then there's been a voting and ranking exercise. So we came up with a list of priorities. And then there's a second call to action to update this list and the voting from June to September this year. And we have an updated list now. So we were wanting to do some voting if we can get the technology to work in this meeting. Marina's looking doubtful.
So the Zoom is actually still working. It's just the projector in the room that's not working. It might work in a second, but if you are on Zoom, I've been playing the presentation with Richard presenting without it. And I could put up the Slido research priority voting. If you would quickly log into Zoom from your respective phones, we could also start doing there. But if this screen works, it should come up and you can just scan with a QR code and join.
So there are two things. There's the survey on the activities, and then there's the research priorities. So we had initially planned to do breakout groups to talk in a bit more detail about each of these, but because of time and also my energy, I'm sure everybody else feels the same. We plan to do it in this room as a large group. So you'll see that some of the list of questions, the research questions are very specific and some are very broad and vague. And we wanted to talk a little bit more about why we think certain ones are more important than others, whether are they relevant to multiple countries, what exactly are we trying to find out for some of them, and a little bit about how we might try and answer these, whether a national program could do it on its own, or whether it would need partners, whether it needs funding. So that was the goals for this session.
I can also do something very, very manually. You can go to slido.com and I'll give you the code to access the survey. So Slido, slido.com. And the code to join, I will repeat a couple of times, 4133-131. This is not the lottery.
41 what?
4133-131.
4133-131. Apologies to the hotel for breaking the projector, if that's what we've done.
Slido, slido.com. And the code to join, 4133-131.
So you can select a question, you just click on it. We want you to select the 5 questions that you think are most important to be addressed for the Asia Pacific region. And we put at the top, we ideally want it to be relevant to 3 or more countries and also contribute to accelerating elimination. So if everyone can do that individually, we'll get some sort of consensus about what we think is most important. And then we'll look at that list and discuss the top few a bit more. Has anybody not found Slido yet? If you need help, put your hand up.
All right, I'm just going to repeat the website and code again. It's Slido, slido.com. And the code for the room is 4133-131.
There's also a QR code on this computer, which is walking around the room. If you want to scan the QR, it's another way to do it. Or it's on Zoom.
Oh, yeah, that's May I ask our Thai team to walk around with the QR code and maybe help our participants join into this session?
So before you choose your top 5, just scroll down to the bottom. That's the RBM. This is Slido. Yes.
You already did.
see something that looks important, just select it. Need to see the results on the screen.
If I could check with the Slido page, and then I'd have to use my computer.
Be on the screen and the winner is. So you're displaying the top three. The top five. Just do top. Yeah, those two. Okay, ready? Okay, so thank you. Are you gonna, do you want to close it? Lock it? Hold on. Can I lock it? Oh, it says two people are still. Two people are still on. Let's not lock it. Let's try.
Don't lock it yet, just
Yeah.
keep going maybe.
So please carry on. We have a clear winner, I think. Results on the screen. The top voted research priority for the Asia Pacific region. I feel like I need a medal or something. What strategies for malaria elimination are best targeted for reaching and addressing malaria transmission amongst migrant or forest going populations? So that does keep coming out as a top priority. Number 2 was how to integrate malaria surveillance with the broader health system. 3, what surveillance strategies are most cost effective and how do we maximize limited resources for surveillance? 4, operational research into how surveillance systems and data are used and where they can be improved. And 5, how to monitor malaria among mobile populations, including mobile and immigrants. So thank you very much for that. You're welcome to carry on voting. This information will be of great interest to a few organizations, including the Global Fund. And I know there's already thinking about what should be in the operational research component of the RIVE 4, amongst other things. So this will be fed through to them. And then we're also going to be discussing in more detail a bit about how to address some of these priority research questions. We were planning to do it in this session, but we'll do it separately at a different time. So if it's okay with you, we're going to finish with one last thing, which, as I mentioned, it's the survey on what the activities we've been doing as a working group over the last couple of years and for suggestions for what we'd like to see in the next 2 years. And for that, we have a different bit of software. Is this going to work? So we're going to use Mentimeter. Would you like to come and explain, Marina?
No, the shortcut. Shortcut? Alt tab? You can't do something.
So you need to go to website menti.com. So MENTI.com. Hey, folks. So MENTI.com, and the number code to enter is 63052151. Can you full screen it? Full screen, please. Yeah. So 63052151. And please be honest, don't be nice.
People voted. No, you have to. Tell them to be honest again. I don't do something. It would be good to take something down.
Anybody having problems that need some help? Put your hand up, please. Great, no problems. We're up to 18. We'll move on when we get to 20. Just need a couple more. So for this one, you need to type, and we should be able to see what you type on the screen. So please be polite. We don't need to organize any if you don't want. It's okay. Thank you for the excellent. We'll organize a talk on how to be excellent. Sounds good. Okay, 10 seconds. Any more ideas? Any requests? Okay, here's the next one. Did you find the online training useful? And I'm aware that there are only certain programs that join the training, but if any of you were in the training, it'd be good to get your feedback. And it's also good to know if you are not aware of it, because in theory, you should all know. Great, thank you. So one person didn't find it useful, and everyone else did or didn't join. Great. So next one. Yep, so this is another one where you can type whatever you like, and we'll all see it. And for this, it can be anything at all, because we have a broad range of partners, I think 50 partners that are not national programs that can help deliver training across many different topics. Is that training for APMEN on how to provide technical support? The last one. So lots of data quality, which is great, and lots about modeling. Quite a lot on different aspects of surveillance. Entomology, where's Leo gone? Getting back. Yeah, so we also obviously communicate this with the other two working groups, buybacks and vector control. And we even may organize some of this training jointly. Any more? 10 seconds. This is a topic close to Marina's heart. Is the newsletter useful? She's sitting here. Close your eyes. I think there's a consensus that we need to keep doing the newsletter. Next. And anything else you would like us to be doing? This can be anything at all. So remember, APMEN is a network of country partners and MCPs, and then partner organizations. There's 50 at the moment. It's slowly going up. More organizations are joining. The scope of what can be done through the network is very broad. Some things are potentially quick and easy and free. Some things over a longer time period maybe need external funding, but this is anything. So a great range of suggestions. I saw a few suggesting support for research, some mentions of different coordination activities, sharing experience and information across the network. We love to do that. We like to organize different mechanisms for doing that. So we're going to take all of this away as a team and digest it and come up with our plan. We will then be sharing this plan, so you know what we're planning to do. And that's it. Thank you. Very, very helpful to get that feedback. So, so thank you very much for that. We are going to close the day just with a couple of remarks from Dr. Ratanasai, our chair. just reflections on the day, and then we'll tell you about dinner. Thank you.
So once again, on behalf of the chair of the SRWG and also with my co-chair, Pupsiri Shamot, and all of you, I would like to take this opportunity to thanks for your contributions and hard works during the first days. I think your contribution have been part of our annual meetings that we have attended in person, and also I would like to thank those who attend online. And I hope that all of our inputs will be utilized for the next planning in the coming years. And I hope that we would try together to find better strategies and solutions for the malaria disease surveillance, so that all of our countries could achieve malaria elimination by 2030. I don't want to keep much time because we have already spent time over. So thanks a lot, and see you tomorrow at 9. Maybe the organizing committee have something to inform. So thank you.
A really short announcement. We have dinner today downstairs, one floor.